And the reason tissue death in the heart is so important or so critical is because heart cells can't divide and become new tissue, right? So when you lose those cells, the only chance is to repair those cells.
As is often the case, your own health becomes a powerful new motivator.
Mm-hmm.
Do you find a second wind?
Yeah, definitely. And it basically, that signal to me was, you missed something. Go back to the drawing board, or maybe not to the drawing board, but what did you miss? I can shed some light or some theories as into why marathon runners tend to have more plaque. And I think I can shed some light on why having higher calcified amounts of plaque, or any plaque in there in general, lead to higher rates of heart attack. Because that's the most important question. You can see that the plaque there, and then you say, okay, that's there, and it associates with higher risk of heart attack. Why is the most important question. So if you understand why, then you can understand an approach to maybe prevent a heart attack despite plaque.
Tell me who you are and what you do.
My name is Dr. Stephen Hussey. Traditionally, or I guess formal training, I'm a chiropractor, functional medicine practitioner. But what people know me for is heart disease because of my story. So I don't actually practice chiropractic anymore. I just recently left that completely, and I work with people with heart disease now. So that's what I do.
Now, I met you really early on. I think both you and I had a few different discussions because at the time, not a lot of people knew me, and I had this interesting phenotype that I was interested in, that had to do with the triad and also this concept of the lipid energy model. And I'm pretty sure this was as far back as 2017, 2018, something like that.
Yeah.
And you had this interesting water hypothesis that was really fascinating. And I think we did a recording on my channel when it was a tiny channel, long before any kind of podcast, or I think even me engaging with researchers at the time. But you were already kind of working on that hypothesis. It was really super fascinating. But let's go back a little bit further. When did you yourself start getting interested in heart disease?
Well, that goes way back for me because I'm type 1 diabetic, and I was diagnosed as a type 1 diabetic at 9 years old. So my entire childhood, I'm going to endocrinologists, for management of this condition, and I'm just seeing on the walls and the offices of the clinics, I'm heavily predisposed to heart disease, heavily predisposed to small vessel disease, eyes, kidneys, extremities, that kind of stuff. So I've always been somewhat interested in it because of that. And so through any formal education as a chiropractor or functional medicine, or even in college, like any class I take where I talk about heart disease, my ears would perk up. So I was got interested in it in that sense. And then it just kind of grew from there. And I had a lot of information about heart disease because I'd just been researching. And a lot of it had to do with, the true function of the heart, which I don't think is to move blood in the body. There's lots of research for that, but also about atherosclerosis and the things that I'm supposedly predisposed to. So I got interested in that a long time ago. And then, so I'd always been interested in health. So in college, I figured out that I could change the way I live my life and have a direct impact on the chronic conditions I had, whether it was the type 1 diabetes, or I actually got rid of a lot of inflammatory conditions. I got rid of asthma and allergies, and I used to break out in hives all over my body, just giant hives from these kind of inflammatory type conditions.
How are you making these corrections?
Mainly diet and just lifestyle stuff. So just exercise and then changing my diet. It was, a very processed food, standard American diet growing up, and went to more of whole foods, and then paleo, and then keto, and then carnivore for a while. So there's just been evolution of diet for me. And I thought that it was interesting that no doctor ever told me that I could do that, could change my lifestyle and have an impact on these conditions. Got a lot of them to go away, aside from the type 1 diabetes, which is kind of collateral damage from that inflammation, I would say. I have theories about that. But yeah, so that kind of got me thinking, what else are they not telling me? What else could I learn? And that kind of started me down this path of healthcare of some sort, because I wanted to be a pediatric endocrinologist because I had a really good relationship with my endocrinologists. But then I started learning this stuff and I was just like, oh, maybe I don't want to do that, because they had no idea what to tell me. Or even if I told them like, oh, I'm having these results, they were just kind of like, oh, cool, good for you. And I was like, okay. So that's why I went to chiropractic school.
It's fair to say that as a type 1 diabetic, at least this has been the standard of care for as long as I've been aware of it, is, and for people who don't know, you have type 1 diabetes, you have insulin insufficiency. You're not making enough insulin. And therefore, the concern is that you don't have enough insulin to put away the glucose that you have coming into your body. But interestingly, type 1 diabetics it's recommended that you have a lot of carbs in order to not get into a state of hypoglycemia from the exogenous insulin that you're taking. So because you have the insulin insufficiency, you need to take insulin, and how much insulin you take has to do with the amount of carbohydrates you consume.
Mm-hmm.
But there's such a concern, understandably, that there could be a hypoglycemic effect, that the glucose gets put away too rapidly from the exogenous insulin that you're having, that you could go into a coma. It's very serious.
Mm-hmm.
So the thought is, make sure you get enough carbs so that you have enough glucose so that that never happens. But there's risks that come with that. Would that be fair to say?
Yeah, definitely. Because then people are just like, all these carbs are okay, and I can just eat more and more and more and just give insulin for it. And now we're talking about, high insulin levels, which we can measure in someone who's not type 1 diabetic, and we can see that's the indication of pathology. But I'm just creating it as a type 1 by just giving myself more and more insulin to cover all these processed carbohydrates, right? And that can lead you to, I know type 1s that are type 2 diabetic as well. They become insulin resistant to the insulin they're giving themselves. So yeah, that's a problem. The other problem in the industry is they're also scared of ketones, right? Because of ketoacidosis, which is very different than ketosis. But that's what they're scared of, because in the early type 1 diabetics, before we had insulin, that's what they saw was ketoacidosis, because their body didn't know or didn't have any insulin, so they couldn't get sugar into cells, so it thought there was nothing available, so it was just making ketones like crazy. And you get into these high levels of acidic levels of ketones. So yeah, there's a huge issue in that industry of type 1 diabetes, and how it's very different, because you get someone on a low-carb diet or a carnivore diet or something, and you're going to see things very different. You're going to have very low insulin levels, or you have to give yourself very low amounts of insulin, and you're going to make ketones, and people are going to freak out. They're like, oh my gosh, you can't make ketones. That's bad. You're going to go into ketoacidosis. And it's like, well, no, if I have insulin around and I'm responsive to it, I'm never going to go into ketoacidosis. So yeah, those are things I had to learn for myself, because I was not told that by doctors. I didn't even hear the word low carb for any reason until probably 12 years after my diagnosis, where I should have been like one of the first options I was given, considering how roller coaster blood sugars were on the standard American diet. So yeah, going back to like why I'm interested in heart disease, it's that mess that I had to go through and sift through that initially got me interested in heart disease. And so once I learned that, I, would eat this whole foods diet and exercise. Those are things that really helped me control my blood sugars. And again, I thought it was very interesting that I never learned that stuff from medicine, literally from my endocrinologist as a kid, which is a great guy. He gave me a book that listed every single fast food item there was at the time of every fast food restaurant and how many carbohydrates are in it, because that's all that mattered. You just count the carbohydrates, you give yourself insulin for it, which became even worse when I got an insulin pump, because then it was just like this store of insulin right here all the time. I didn't have to inject. It was just whenever you needed it, just give yourself insulin. And so yeah, that was an issue. I don't think I was ever insulin resistant, though. I don't think I ever got to like that point, even though I was eating tons of carbohydrates and giving myself a lot of insulin for it. I was always just so active playing sports. And I think that helped a lot. So yeah. And then, diet, exercise is what I mainly did. That's, especially as a student going through school, that's what I could do, what I could afford. I could control those things. And then I guess it's been almost 5 years ago, I had a heart attack. I had a Widowmaker heart attack, which is, I'm sure, something we'll talk all about today. Yeah. So to my surprise, like there was no signs of this. There was no angina, heart disease, never had any imaging before, so I didn't know if there was any prior. And we'll talk all about that too, I'm sure. But yeah, so it's just kind of out of the blue. Now, the reason that I initially found you, because this was around that time, this was after the time when we initially talked, was because low carb diets made my blood sugar go up, or not my blood sugar, my cholesterol go up, right?
Right.
So that's why I was just like, oh, that's interesting, which, because, they've tested my lipids my whole life. And it's interesting that before I went on a low carb diet and, would get lipids tested all the time at just every 3 months as a type 1, they're recommending statins just for whatever. My lipids were fine, according to them, quote unquote, fine. Just standard of care for a type 1 diabetic who'd been that type 1 as long as I had. It was a statin and basically blood pressure medications to protect your kidneys. That's what they wanted to do. But there was no issues. That was a standard of care. So I was familiar with rejecting statins. And then when the cholesterol went up, when I went on low carb, it was pushed even more, right? So that's when I originally discovered things you were doing. At that time, you were just this guy who is testing yourself crazily, and seeing the things, which is brilliant, because I know now that a blood test is one snapshot in time. So when you were testing it like that, I was like, oh, that's so much smarter. Just like that's why CGMs work so well. They're game changers especially for people like me. It's because you see what's happening real time.
Right.
Otherwise, you don't know anything really. You just see what it was at that point in time. And so I liked that. And so that's why I started, following your stuff. But it also gave me some theories as to why my cholesterol was going up and was that a problem or not. So you could say that the only thing that was quote unquote wrong at the time of my heart attack was that my LDL had been elevated for 2 years. So I'm sure we'll go into all that.
Yeah, I mean, for sure. If somebody's listening right now who's more pro LDL lowering, they're going to say, well, of course, you were turning down statins this whole time. As a type 1 diabetic, you're at a greater heart disease risk. That's well established. I, by the way, had the honor of interviewing Dr. Bernstein, and wished he could have seen the documentary that we're featuring him in that interview. But he is a type 1 diabetic who lived to freaking 90. And again, if you know type 1 diabetics, I'm sure you're aware.
Okay.
Unfortunately, the heart disease risk is already super substantial. So to your point, it is standard of care that anybody who's a heart disease risk would likely be prescribed statins. And that would be what we pressed on. So anybody listening at this point in time who's pro LDL lowering is saying, well, of course, that's just what happens. When you don't take that advice, you were probably developing a lot of plaque. And voila, you end up having an MI at an earlier age.
Yeah.
Now, to be fair, on top of that, if I'm not mistaken, this also had some very awkward timing in that you were close to publishing a book by that point. Is that right?
Mm-hmm. Yeah. So, I realized that I had a lot of information about the heart and heart disease. So not just about atherosclerosis, but about heart failure, heart attacks, all this stuff, the true function of the heart. So I had started writing a book about the topic because it was interesting to me and it was pertinent to my life. And I was getting close to finishing it when this happened. So yeah, it was awkward timing, like you say. And so I had to reevaluate some things, not necessarily what I put in the book, because as I thought about it, nothing in the book changed and nothing has changed, but more of like, should I be doing this? Am I even am I even legit? I had this heart attack. There's a lot of self-doubt, a lot of demoralization, from me in that setting, especially in the hospital. Like it was during COVID, there was nobody allowed, visitors or anything. It sucked. Right?
Can you talk us through the whole thing?
Yeah. So
it's a long form podcast. So
sure, we got time, right?
Exactly.
So I had the higher LDL for 2 years, always in the context of good metabolic health, low inflammation. HSCRP was always lower than 2. And always even low Lp(a), all this stuff. It was all fine. It was just the higher LDL. Sometimes triglycerides would be a little elevated, but insulin levels were always fine. It's hard to tell that with a type 1 though. Like, is that insulin level really accurate because I'm injecting rather than it going right into the bloodstream? I don't know. But everything else seemed really good. And like I said, I was always very active and everything. So yeah. And then 6 months prior to the heart attack, I was seeing a nurse practitioner for endocrinology, and she recommended I do a CAC score. And so I went and got one, and it was a perfect score of 0. No calcified plaque. and that's just calcified plaque, but that technically puts me at very low risk of a heart attack. If you look at the studies, it's like 1 to 1.7% risk if you have a score of 0. And then 6 months later, here I have a heart attack. Now, in that 6 months, he was during COVID. There were things happening during COVID that I didn't agree with. It was stressful. I got caught up in things that I usually would never get caught up in. Election, social injustice, all this stuff was happening. And lots of times I would just kind of like push that aside, but I let myself get caught up in it because it had to do with health, and I was always interested in health. So that was happening. And then I was pretty dehydrated, and that was because I kind of convinced myself to drink water when I was thirsty, and that was it, which, we could talk about hydration and everything, but I had been dealing with constipation because I was doing that. And I was getting ready to do something about it. I was like, okay, my body's telling me this is not okay, but I hadn't yet. So I think that may have been a contributor. And then a day and a half before the heart attack, I got some pretty stressful news about a close family member. And it wasn't just the news. It was the inability of anybody of me and my family to get to this person and help them because they were in another country. And it was during COVID. You couldn't fly anywhere easily. So yeah, we were just kind of sitting around hoping that this situation was going to be okay. And so I didn't sleep. I got the news Sunday night, didn't sleep well. Sunday night, didn't. And Monday, just the whole day tried to figure out how to get to this person and just couldn't make it work because of all the things in the way. And then Tuesday, didn't get a good night's sleep. Woke up Tuesday morning trying to distract myself. I did a very intense workout Tuesday morning, pretty much first thing, where I would sprint up a hill, drop and do push-ups to failure, do lunges to failure. I did that like 5 or 6 times in a row. And then maybe 25 minutes later, I was cooking my first meal of the day, and boom, I started getting pain right here in my chest. And it wasn't ever up into the neck or into the arm or anything like that. It was just right there in the chest. And at first I was just like, oh, my pec's tightening up, too many push-ups, And then I started to get really flushed and hot. And it was January, so I went outside because it was colder outside. And it just kept getting worse. I kept getting more flushed and hot. And I was like, okay, something's not right here. And so I called the ambulance. I was on myself. So I called the ambulance, and they were there within 5 minutes. And by the time I got in the ambulance, it was pretty bad. It was the worst pain I've ever had in my life, and it just kept getting worse. And yeah, I was pretty certain that's what was happening, but you're always in the back of my head. I'm like, no, that's not what's happening, but I was pretty sure at that point. So yeah, I went to the hospital. They did the EKG and said, prep to Cath lab. And so, I was awake and conscious during the entire thing, and never really felt like, oh, this is it. The only thought I had about that was, at the time I was married, and I was like, oh, well, we have life insurance, so she'll be able to pay off the house and all the debts and stuff like that. That's the only thing I thought about. Otherwise, it was just like, okay, this really hurts. Please make this stop so that I can get on with things. That was kind of my mentality, and maybe that served me.
But you were literally contemplating, hey, this might be the exit.
I don't know that I ever thought that. I know
because you were thinking of the insurance.
Yeah, that was the only thought that I had that made me think, oh, I'm gonna die. The other than that, I was just like, just make this stop. And I was laying there in the room they put me in before the Cath lab, and they were like, there was just hands all over me, like peppering me for the Cath lab. And I remember telling them, like, do something to stimulate my parasympathetic nervous system, because there's a whole theory or explanation of heart attacks that has nothing to do with the plumbing whatsoever, which we can talk about if you want. So yeah, like I was like actively trying to and they were like, treat myself, help them treat me, sort of thing. Just because I had this information, I was writing this book, and I knew of this mechanism of heart attacks that has nothing to do with the plumbing. So I was thinking, that's got to be it. That's got to be what's happening based on the stress I was going through. So I was like, we have to stimulate parasympathetic. So anyways, yeah, I never really thought this was it. I don't remember thinking that, or being scared that this was it. I don't remember thinking that. I remember thinking, okay, let's make this stop, please. Like, you guys do what you got to do, because it was literally the worst pain I've ever had in my life. And it was just relentless. It's just constant pain. There was no like surges, ups and downs. It was just there. And so, yeah, they went in. They tried to go into my wrist at first, and that didn't work. So they went into the groin, and they went up and they found 100% blockage of the LAD. And they placed a stent. And this may be interesting to you. I could argue that it wasn't that blockage. I don't know for sure if it was or not, because I have for various reasons, and we can talk all about this. But one is that there was no calcified plaque in my arteries. It's hard for me to believe that 100% blockage happened without it being an acute clot formation where it just instantaneously happened and none of it got calcified.
Well, there's another thing just that I did want to zero in on. You said that your cholesterol was elevated from going low carb for 2 years.
About 2 years, yeah.
Yeah, about 2 years. So even pro LDL people in the room right now
will say it takes years.
Yeah. Or either that, or we need to talk about my study.
Yeah.
Because that's the biggest hand wave of my study, is that they constantly say, well, you need decades or whatever to get that figured out. But that given that you're talking about 100% blockage, I am surprised that you would not have had any symptoms up until that point in time. Because not that you couldn't have, say, a 30% occlusion and not know it, or even as much as, like, say, a 70% occlusion in some cases.
Mm-hmm.
But in the Widowmaker, 100% blockage, like, that's impressive. That's
Thank you.
I would expect symptoms before then if this was ongoing.
Right. Yeah, and I have my theories about, there's so much to talk about here, because obviously this is very personal to me, and I had to figure out what causes heart attacks from my perspective. And, I don't know what exactly would happen to me, and nobody will ever be able to tell me, even myself. But I have come up with a lot of theories and found out a lot of things that frustrate me about what I was told as far as what medicine told me.
I don't want to jump ahead in the story, but I am curious and I want to know, have you had successive imagings since then?
I've had one. So I
don't jump to that yet. We'll get to it. Let's go back to the event itself.
Yeah, sure.
So this is my guess. My guess is you're getting rolled into the Cath lab and you're saying things like parasympathetic system and so forth. I doubt that they're very receptive to what you're pressing and suggesting. Like, they're very much standard of care, and there's enormous immediacy when it comes to dealing with an MI. So they've got you in the Cath lab. They're identifying, once they've got it, and once they're going through your groin, that you've got 100% blockage. They're placing a stent at that point, I assume.
Mm-hmm.
Are they placing any other stents, or is that the only one?
Nope, just that one. He said there was really no plaque anywhere else. There was this very small amount of plaque in the RCA, but he said it was like worth not even noting, so it was just this 100% blockage in the LAD. And so they did angioplasty, placed a stent, and I felt better. But they also gave me morphine at the exact same time, because I heard him say, give him some morphine. I was like, finally, because I'm hurting here, and so they gave me morphine. I don't know the exact time. I couldn't feel when they placed the stent. I wasn't looking at the screen or anything like that, but I know that it was right around the same time that they said morphine that they were done, and I felt better. So is it, again, like, we can talk about this other mechanism of heart attacks. It'll make more sense. But did they open the stent, restore blood flow to the artery, and that was causing the heart attack, or did they calm the nervous system with morphine? And all of a sudden I stopped having this response that can create tissue death. I don't know, and I'll never know. But the mechanisms of how you prevent those two things going forward, I feel, are the exact same things, which I'm sure we'll get into as well.
Sure.
So the point is, at this point, I could argue, or I don't know that it was that blockage, because I have no imaging other than that CAC score beforehand. And if there was no calcified plaque in that LAD, it wouldn't have shown up, if it was there, or there was nothing there, and then a clot formed instantaneously and blocked the whole thing.
It's so unusual. What you're describing is, and by no means am I an imaging expert, but I've come to find that there are the two most common scenarios are, if there's development of plaque, it may develop predominantly in one vessel. The LAD is the place, right? The Widowmaker is a lot of. However, typically by the time you've got as much as, like, say, a 50% blockage, there's probably a significant amount of plaque in other coronary arteries. That's usually in the case of somebody who's metabolically unhealthy. Now, there is this phenomenon, and I have, in fact, interacted with a number of people for which they might be a runner or exerciser of some kind, and they do have this strange phenomenon where they have a lot of blockage in one coronary artery. It's It's usually the LAD. Sometimes it's circumflex. Sometimes it's the right coronary artery. It's interesting. But that is the one time where you might see something. However, whenever there's a high occlusion of the times that I've seen it, there's calcium. It's usually something that's been ongoing for a while. It's very rare to see an acute, super high degree of occlusion. Again, not an imaging expert. I'm only speaking anecdotally. What you're describing right now is not something I hear about like ever. I don't think I've ever heard a story like this.
Mm-hmm.
Not a particularly, like if you had said, I had a CAC score 5 years earlier or 10 years earlier, it might make more sense. But even then, I'd still expect that when they went in, they would, I don't know. It's
well, yeah, wait till we get to what's happened since.
Okay. All right.
Yeah.
Yeah.
So
yeah. So you get relief from getting the morphine. You're now on the other side of it from your opinion. The stent's been placed.
Yep.
Okay. Now you've got post-op. How did that go?
Yeah. Yeah. So obviously at that point, pretty demoralized, and asking them at that point, like throwing my hands up, hey guys, what do you got for me? Like what caused this? At this point, I wanted to know their opinion because obviously I got something wrong, did something wrong. So yeah, and it was just broken record. Your cholesterol's high, whether it was a intern, whether it was a attending physician, whether it was a student in there, it was all your cholesterol's high. And I knew enough about things or had enough doubt in that theory to think, well, I'm not just gonna, put on my cards or put on my bet on that, like I'm just automatically accept that theory now just because this happened to me, which some people out there may say that I'm stupid not to do that. It's like, this happened to you. Why are you not paying attention? But when they hear what's happened to me since and what I've been able to do, maybe they'll think a little differently. So didn't know what I was going to do at that point, but they wanted me on 5 medications the rest of my life. They wanted me on 2 blood pressure medications. They wanted me on a statin, obviously, and then a blood thinner and then that baby aspirin for the rest of my life. And, it's pretty, as bad of a place I was in at that time, I was completely reinvigorated 3 days later because of the experience I had in the hospital. And usually people are in there for like a week, and I was just like, you got to get me out of here, because it was just like the food they were giving me, especially as a type 1, or the recommendations as far as the medications go, even though in my head I know that those medications were not what I needed. It was cookie cutter recipe. This person had a heart attack, here you go. And an example of that is that my blood pressure has always been fairly low, normal, right? So 112/70, things like that is what it's been. And they gave me 2 blood pressure medications. I took one of them for one night, and I woke up that night, and I remember, like, wake you up 3 times a night in the hospital, take your vitals and everything. I remember looking over at the blood pressure monitor thing, and it said 90/50. I was like, that's pretty low. I took one,
Wow.
And they wanted me on 2. And so then they left the room, because people would argue that that's not terribly low, but it's much lower than what
90/50.
Yeah, it's low, right? But anyways, so then they left the room, and I realized that it was really hot in the room. So I go to get up, and I didn't get up fast because I have all these wires hooked to me. So I got up, I sat there for a minute, and then I stood up to go turn on the thermostat, and I almost fell over and passed out.
Of course.
Yeah. And so I was just like, and they wanted me on 2. I don't even remember which one I took. It was an ACE inhibitor and a beta blocker, but I don't remember which one. So anyways, I was like, I'm not taking that anymore. And then the other thing I did is I took a blood thinner for 6 months. I took Parasympathetic because there's a stent in there, foreign body. Don't know how your body's going to react to that. So, they say a year, but and this is not advice or anything, but that's just what I chose to do. I talked to a cardiologist who's more in the know with the way I align with health and everything, and he said, yeah, the 6 months would probably be good. So that's what I did.
Yeah, we'll definitely inject the standard, which is nothing we're talking about here should be taken as personal medical advice. And you are in charge of your own health.
Mm-hmm.
So you take the risk that you decide to take. I will concede the blood pressure thing. And granted, usually when I'm talking about standard of care with people on this podcast or just elsewhere, it's almost always in the context of lipids. But blood pressure, like if you already have a fairly healthy blood pressure, why would it just be why would it be a cookie cutter to prescribe something for which, if your blood pressure is in good shape for what it is, like why?
Well, I mean, their arguments are that anybody who's had a heart attack is at very high risk for heart failure now. But again, they're not looking at me, 34 years old, fit, healthy, like not at super high risk for that anyways. 80-year-old person has a heart attack, comes in there, has damage to the heart. Yeah, probably much higher risk for heart failure. It was just standard of care, cookie cutter recipe. And that's what they gave me. And I feel put me at risk of low blood pressure, really, which low pressure acutely is more dangerous than high blood pressure in the acute situation,
And it's just, I can't help but feel in this moment like this is a remnant of the populations they're doing these studies on.
Mm.
So somebody has an MI. What is the population pool that they're working with that the study is based on? And it's probably people who do tend to be hypertensive. And therefore, even for those who are not qualifiably hypertensive, they're hypertensive by our standards.
Mm.
And therefore, they get efficacy from, providing the blood pressure medication. But this is why more studies just need to be done on healthy people who otherwise have the event.
Right.
So that we could see what the standard of care should be for them.
Yeah. And, from my perspective, looking at literature, like especially Framingham data, like high blood pressure is only really increases risk at 70, 80% above normal. They also keep changing the goalposts of what's normal. Right. So I don't know, you could say that the lower the recommendation, the more people need drug, right? When in reality, it's only been shown to be dangerous at 70, 80% above normal for blood pressure. So there's that. So yeah, but their thing, or at least what I was told in the hospital, was that we're trying to take pressure off your heart while it's healing so you don't develop heart failure. So that was what was preached to me there in the hospital. The other thing that was preached to me was the diet stuff. And I literally got pages of what I was supposed to eat. So low salt, right? Obviously for trying to prevent heart failure, which we could talk all about that too and how that's wrong. But also a processed food diet. Literally they told me to eat a processed food diet. And things like fig Newtons and animal crackers and vegetable oils were on the list of things that I should eat to be healthy.
Are you summarizing what they're saying as a processed food diet, or are they literally saying?
But what they were telling me to me was a processed food diet. Yeah, what they were telling me to eat.
Yeah.
And the standard stuff of low fat and
fig Newtons.
Yeah, fig Newtons, animal crackers, vegetable oils are on the list, right, of things that were okay to eat. As long as you avoided the fat and avoided the salt, And so, yeah, it just reinvigorated. The other thing that reinvigorated me was that I had questions, and I'm not like a pretty combative guy or anything. I'm just asking questions, especially at that stage. I was like, hey, I got something wrong. I'm asking the attendings questions, and it's just shut down a conversation. I was talking about blood thinners. I was like, what about magnesium as a blood thinner? And he was just like, magnesium's not a blood thinner. Well, I know that not to be true, that it can act as a blood thinner. I knew of studies where, and I don't expect this to be a procedure they have in a hospital setting, so I didn't expect that or whatever, but I also knew that what he said was wrong. But it wasn't even curiosity or anything like that. It was just no, and the shutdown of conversation was just bad. And even the last attending that came in, which I met, it was the day I got discharged. The last attendant came in and said, well, I don't want to have the conversation about medications because I can see in your chart that you're not going to do them. And I was like, okay, so somebody branded me in my chart as non-compliant and you don't want to talk to me about it, even though I'm willing to talk about it. If you have something different to say, I want to hear it at this point, And so it was just, there was no conversation. But back to the magnesium thing, there are animal studies where they show that intravenous magnesium is just as effective as blood thinners at preventing clot after stent placement. So why isn't there a procedure developed for humans because of that, or things like, why has that not been done? Well, because it's not profitable, obviously, so they want to use the blood thinner. And so, but that's just one issue, and that's just a very small one, but that's just the thinking, that's the mentality, so that's what frustrated me. That's what reinvigorated me. So I went home after 3 days and started my own routine. I didn't know exactly what I was going to do or what I was doing at that point. All I knew is that at the time, I was very familiar with the research on infrared sauna and its success and treating people with heart failure or preventing heart failure. So I bought a sauna. and because that's what they scared me. Like, you're going to develop heart failure. You've had this damage to your heart. So I started using the sauna. And then I thought, well, the original source of infrared light is the sun.
I hate to pause you, but
Yeah.
we really should make a distinction between heart attack and heart failure, because a lot of people might think we're talking about the same thing.
Right.
Could you unpack that for a moment?
Sure. Yeah. So, well, heart attack, people say heart attack and they could mean one of two things. They can mean cardiac arrest, which is like a heart signaling issue where it starts to signal so much or so arrhythmically that your heart literally goes in like tetany and just stops beating like it's supposed to. And then there's myocardial infarction, where the theory is that there's lack of blood flow to an area because of a blockage, and that causes tissue death. And I think that is one thing that could happen, but I think there's an entirely different mechanism as well.
And the second is what you believe you had.
The second, yes, that is what I had. I had heart tissue death in the septum of my heart, between the two ventricles. There was tissue death there, and they found that echocardiogram. My ejection fraction after the heart attack had dropped to 35%, which normal is 50 to 70%. So that's the ejection fraction, is how much blood is leaving the left ventricle in each contraction, and it should be around 50 to 70%. And mine had dropped because there was damage to tissue there, so it wasn't contracting as much as it should be.
Right. Specifically at the place where you actually have the embolism, right? That's what I'm wanting to say, where you basically have the cutting off of the oxygen that's downstream. Tissue starts dying, which is why every second counts.
Yeah.
Because those cells that are below there are not getting the oxygen that they need to stay alive.
Right. Yeah. And that's the theory anyways, because if you look at Giorgio Beraldi's work, which we'll talk more about later, when he mapped the arteries of the heart. So Beraldi invented that technique you see at Body World exhibits where they have the arterial map. He invented the technique of how to map that with the neoprene or latex solution, where you inject it into the arteries and then it hardens and then you dissolve away the tissue and you're left with this perfect cast of the arterial system. So he did that on thousands of hearts in his career. And he found that the blood supply to the heart varies dramatically in individuals. Some people, the RCA is the major supplier of blood. Some people, the circumflex supplies over a third of the heart, and sometimes the LAD is not the major supplier. So, and as far as I know, maybe there's somebody out there that knows different, but as far as I know, there's no way for us to tell what I am. I mean, you can be right or left coronary dominant. They can tell that kind of stuff, but how much of my heart was supplied by the LAD, and does the tissue area that died match up with that? I don't know. But Beraldi's work suggests that it could be very different in different people. So I don't know. And again, that'll make more sense later when we talk about this other mechanism for attacks.
That's fine. But we'll bring it back now to heart failure.
Yeah.
So now that there's been tissue death, that becomes relevant on the heart failure discussion.
Right, because the heart is a muscle and it's contracting. I don't say pumping because I don't believe the heart is a pump. At least not a true pressure propulsion pump like we think of it as, but I say contracting. And that contraction is what, gives the blood a little push. And it kind of creates this, really it's creating a vortex. So as it contracts, it kind of spins. People can see my hand. Yeah, they can. So it kind of spins like this. And when tissue dies and that contraction is not happening properly, now we get this different type of contraction. Like maybe only half of it's contracting over here because the tissue's dead over here, or it's healing over here. And the reason tissue death in the heart is so important or so critical is because heart cells can't divide and become new tissue, right? So when you lose those cells, the only chance is to repair those cells. And so that's part of my routine that I did, was trying to help those cells repair, which infrared light has been shown to do that in rat models. So that was another reason I chose infrared sauna as one of my things. So yeah, but heart failure is now, when that's happening, now, the amount of blood that should be leaving the heart is not leaving the heart. And what happens in heart failure is we get this congestion, right? So fluid is not moving properly. And we're going to talk about different ways that fluid can move in the body too. It's not just this pumping heart, because I don't believe it's the main mover of blood in the body. And there's lots of literature to support that, but they call it heart failure. And I would say that's a misnomer, that it's not the heart that's actually failing, but something can go on in the heart, like tissue death, that can contribute to this congestion, or it lead to the heart not, contracting like it's supposed to, which can lead to this, it can interfere with the flow of the blood through the heart itself, and that can create congestion in areas. So, or it can increase the risk of clotting. But when that happens, people have to understand that the heart is a vortex. It's shaped like a spiral. Like one end of it looks like the end of an American football. So when it contracts, it's spinning. And that spinning is critical to so many different aspects of our physiology, but it's really, really important for the movement of blood through the heart itself. So when you get tissue death somewhere and that spiraling like that doesn't happen, now the heart, when it contracts, it starts to just kind of do like this in certain areas, and that can lead to this expansion. So now we look like, instead of having one end of the heart shaped like an American football, it starts to be shaped like a basketball, and that is a problem because, again, this is all based on these hemodynamics of blood flow through the heart. And that's interrupted when this happens, when you get tissue death. So they're trying, like their approach is, that's much more likely to happen now that there's tissue death there. Let's take pressure off the heart by lowering your blood pressure. That's the justification for these blood pressure medications. If your blood pressure is already low enough, I don't know that that makes sense, but that's just me. That was just my example.
Right. I encourage anybody to check out the arrangement of the muscle itself that the heart is utilizing, because it's more like straps. It's less like how you think of a bicep or something like that, where you've got two ends on either side. And then it actually, exactly as you said, it only has to squeeze. It has to squeeze in a twist in the way that you're describing. It has to do with the arrangement of the chambers on the inside, which also are very carefully placed. But then you get into the whole electrical side, which gets super fascinating. And that's where you start to understand how defibrillators work. It's not just as simple as get struck by lightning and that'll...
Yeah, it's not just the orientation of the muscle fibers. It's also the rhythmic signal of contraction that's electrical that needs to happen in a certain way to make sure this device happens and it does on time. So as the blood's coming in, it's, one valve is opening and then something else contracts and then that pushes it out this way. And it all has to happen on time. If it doesn't happen on time, we get backflow. And that's what now the heart is being forced to be more of a pump than it's supposed to be, because it's not a pressure propulsion pump. And there's lots of literature that shows that it can't be. There's no way that it could be efficient enough to do that and pump blood throughout our entire body. But if then it gets off, now we get this backflow, we get these pressures where they shouldn't be, we get this expansion of a ventricle, and that makes it more like a basketball. That's heart failure. But I would argue that the heart is not what's failing. It could be the electrical system. It could be the damage to the heart that's just not able to, or it could be that there's other mechanisms outside the heart, like in the periphery, that are putting more pressure on the heart, making it be more of a pump than it's supposed to be. And that's not a good thing either, because it's not supposed to be that. So, yeah.
And this is why this is a recurring theme for me, not just in this podcast, but for me in just conversation, is you could be very much a pro LDL lowering. You could believe in the lipid hypothesis straight up. What's difficult to sell is that there's such a level of causality applied to it that we don't have to be as curious as you're already expressing right now. Right?
Yeah.
Like exactly what we just now talked about, the fact that you had your elevated LDL for 2 years, the fact that we don't have any calcification in spite of this massive occlusion, that should draw curiosity, like already. So the fact that they could then look at your lipid level, okay, it's the high LDL.
Exactly.
Curiosity. What would have happened if your LDL was 50, right? What then happens? Could we count on some curiosity?
Right. When their excuse is not there, would they have been curious?
And we would hope that they would be, right? By now, you're probably familiar with the keto CTA study. I don't know if you've been following along. I don't know if you heard of the more recent data, but all of our analyses, all of them, even the Clearly analysis, there is no association between LDL and ApoB and plaque progression. Does that surprise you? No, but I want to be a good scientist. It's possible in the 5-year scans. It's possible some relationship appears. But again, I'll go back to, you could absolutely be watching this right now, and you could absolutely believe it has some marginal impact. You could believe it and say, it's just that it takes a lot, and it takes a long time, maybe more than we thought in people who are healthy, like lean mass hyperresponders. But that doesn't get you the get out of jail free card on being curious about what happened to Stephen.
Yeah, but that segues right back into where we need to go and what happened to me.
Right.
And because when you see what happened to me, and I'm just an N of one, it's your point right there. Like, how could this have happened if that theory is correct? Right.
So
here's the whole story, I should say.
Right. So now you're finding yourself into phase 2 of being back on your own with trying to figure out what happened. You have your manuscript together for the book.
Yeah.
You had your kind of, internal crises of trying to better examine it. But as is often the case, your own health becomes a powerful new motivator.
Mm-hmm.
Do you find a second wind?
Yeah, definitely. And it basically, that signal to me was, you missed something. Go back to the drawing board, or maybe not to the drawing board, but what did you miss? Which allowed me to dig deeper, which is where, because I had already been developing, like you said, we had met before then, and we recorded a little bit about this theory about water and the arterial system. And so I was just like, maybe I should look into that more. And when I did, I learned a lot of things. But initially, when I got home after the heart attack, I didn't know that what I was doing and what was going to happen with this stuff. I just started doing it. And so what I started initially was the infrared sauna. I started doing that every single day for about 20 minutes. I started prioritizing sunlight, and I started prioritizing, and since I was outside more, I was in contact with the earth more. I was grounding. So I don't know if people think about grounding, but we can talk all about it. And when you learn about it from the perspective of structured water and its effect on the vascular system, it makes a lot of sense. To me, it does. So that, and then the other thing I did, I took a few supplements. I took serapeptase for 1 year, just a year. I couldn't even tell you how much I took, because I was just, they said take 3 a day.
What is it?
Serapeptase, it's one of 3 enzymes that people could take that break down fibrotic clotting tissue, which is what plaque is for me. When you look at studies that show, analyze plaque, it's a large percentage of it is fibrotic clotting tissue. And I've had pathologists reach out to me and say, yep, when we study plaque in the autopsy labs, so we look at it and it's clotting tissue. That's what they find. Is that what it is initially? No. Talk about that. But so yeah, I was trying to dissolve plaque. They just told me I had this 100% blockage in there. I was trying to do that. And then I also took some things to help the arteries heal. Taurine, which is an amino acid we find in animal foods. Primarily, you can find it in some plant foods too. I took L-arginine. I took a supplement called Wabine or Strophanthus, which has been shown to help signal parasympathetic signaling to the heart. Again, very effective for people with heart failure. Again, I was trying to prevent heart failure, so I started taking that. I took these for I took some magnesium too, as far as the blood thinning effect that I found in that thing, which was different than the studies I found, which were intravenous. This was taken orally, so I don't know. But that's what I took, and I took those for about a year. So just keep that in mind. I only took the supplements for about a year. And I also started setting my circadian rhythm by syncing my body to the day-night cycle of the sun, by being very conscious of my light environment. That didn't happen until about maybe 4 or 5 months after the heart attack, though. So that's what I was doing. In the initial 3 months after the heart attack, I went back and got another echocardiogram, which is a follow-up that they recommended. And it showed that my ejection fraction had returned to 55%. So it's within the low end of normal. And that the tissue that was damaged after the heart attack, it was severely akinetic. So it was not conducting that electrical signal very well. And it was only mildly hypokinetic after that, after 3 months. And, some of that would have happened naturally. My body would have tried to heal regardless of what I did. But they told me that was a pretty good turnaround, 3 months, that things were functioning pretty normally at that point. And the cardiologist at that time said, well, it sounds like you started taking medications or decided to take your medications. And it's like, well, actually, I'm just taking the blood thinner. And he was just like, oh, well, and then didn't really say anything about it, because that's just what my experience has been. So anyways, it was about that 2-3 month mark that I started exercising again, or trying to. I would just go on walks and stuff. And the faster I walk, I noticed that there was pain in my lower right leg, pretty significant pain that was not there at any capacity before the heart attack. I mean, literally that morning I had the heart attack, I was sprinting up a hill with no problem. And so I was like, this is weird. And just like, I was like, I have deep vein thrombosis, like some kind of clot in there, to have compartment syndrome, like what is going on? And it took me so I had the heart attack in January. It wasn't until July that I went in and finally complained about this and was just like, what's going on? And they did a ultrasound of my leg, and they found that there was a 70 to 99% blockage of plaque in the artery in my lower femoral artery in my thigh, which was restricting blood flow to my leg. So if I'm just sitting there, I felt no issue. But if I tried to exert myself at all, it was very, very painful. Like if I tried to run fast, like I tried to play soccer one time, and no way. Like just one sprint and my leg was killing me. So yeah, which makes sense. You're not getting blood to an area. But the thing is that it was totally normal. 7 months prior to that, completely normal.
So okay, yeah, but this was the site of the catheter,
right? So that's what happened from my perspective, and I've had vascular surgeons deny that this happens, but I've also found literature that the heart cath procedure they go into the femoral artery in your groin, and they use this device called an angioseal afterwards, and the angioseal they use so that so that it clots up and heals quicker, so that I can sit up after 12 hours, right? Otherwise, you have to lay there for like 3 days. And lots of people they have issues with bed sores and clotting and those types of things when people have to lay that way. So they use the angioseal device so people can sit up and move around quicker. However, that angioseal device, like what happens is like, here's the artery and it tries to seal it like this. There's a part of it that comes in to the artery like this. So it's like in the lumen, right? And so I found that there are issues. Like there's nothing definitive. I haven't found anything that shows that, yes, this can be a cause of this, but there's issues of people developing clotting. I've had a handful of other people say the same thing have happened to them after an angioseal device. They develop PAD, peripheral artery disease, in the lower extremity on that side. And it's just, despite the vascular surgeon I had just kind of denied it, like, oh no, that's not what happened. I sent him a bunch of literature, like, what do you think about this? And he was like, no, that's not what happened. And I was like, okay. The morning of the heart attack, my leg was fine. 2 months, 3 months after the heart attack, now I can't even walk without pain in my leg, and it's on the same side I did the heart cath. I've got plaque here, like that. There's got to be something going on there, like, to be that drastic.
Do you know for sure it was that exact entry? Well, not that entry point necessarily, but that vessel, that
the femoral artery.
Yeah.
Yeah. Mm-hmm. Yeah.
Okay.
That's the one they go into. Now, then the groin up here, the angioseal device is up here in the groin. The PAD I had further down in the leg, and the most common place they get PAD in the leg is like the distal femoral artery, closer to the knee. And to me,
but the ultrasound where it found the occlusion was up or down?
Down, closer to the knee.
Interesting.
Right.
Okay.
So, because there are issues, like in the literature, I found the angioseal device can cause occlusion there at the site where the angioseal is. But I also found things that show that it can cause clotting issues down the leg, like a clot can form and flow down, and that type of thing
right.
can happen. But hopefully we'll get into this. Like I have a big theory about blood flow dynamics, and that plaque forms through altered blood flow dynamics, or it's one way that it can form. If you have stagnant blood, it's going to clot. And that can be, or if you have stagnant blood, it's going to cause a response from the endothelial lining that results in a clotting response in the intima layer. And we'll talk about that too. But I think that's what happened, that there was this thing in the femoral artery there, and as blood was flowing past it, it was creating eddies and disturbing blood flow, and it was kind of pooling up right there, and I developed plaque right there. Because that's the only thing I can think of. My LDL didn't change. It stayed the same because my diet stayed the same. So, that whatever, like my blood sugars are the same, all the other factors were the same. I wasn't as active at first, but then I found out I could ride a bike and it wouldn't hurt my leg because I wasn't using the calf muscles like I was if I was running and stuff. So then I got as active as I was before. I was still lifting weights and then biking now. So yeah, the exercise stayed about the same. Stress stayed about the same, maybe even got worse after the heart attack at times. It probably did get worse for various reasons. But yeah, so those are things I did. And then I developed this plaque in my leg. So the vascular surgeon at the time said, let's not mess with it, because you can do most of the things you do in your life. You just can't do some of the things you enjoy. Like I couldn't play soccer, couldn't snowboard, couldn't hike, couldn't walk fast to the airport, really. So life was just a little bit different in those aspects, but I could work and do things like that. So he said, let's leave it alone, because when we start messing with them, they get worse, especially type 1 diabetics. They seem to fare worse than even type 2 diabetics with peripheral artery disease, which I was unaware of until I looked at the literature. So we left it alone, and I kept doing my thing. I kept doing my sauna and grounding and sunlight and setting circadian rhythm, and took those supplements. But then a year after the heart attack, so that January following year, I stopped taking the supplements. I don't know exactly why. People ask me why, and I'm just like, I don't know. Maybe I just got tired of taking them. I'm not huge on supplements to begin with. I just stopped. So anyways, I went back to the vascular surgeon a year after that initial diagnosis, and it was only 0 to 50% blocked. That's what it said at that time. And
that same artery in the leg.
Mm-hmm.
Gotcha.
Yeah. And I have good inter-examiner reliability because her name was Doris, and she'd been doing it for 35 years. And so she was a good tech. She'd been doing this procedure. So anyways, at the time, Doris left the room and then came back in 5 minutes later and said, they saw something they don't usually see. We're going to do the test again. And I said, okay. So she did the whole test again, same result. And the vascular surgeon came in and said, well, we can't say it's better because we don't see these things get better. I was like, those are his exact words. And I say that everywhere because those are his exact words. And I was like, well, that doesn't quite make sense, but okay. I'm just happy that it's better. Great. And so
did you feel a difference?
At that point, I didn't know because I was still just doing things that didn't hurt. But I did feel a difference. So then I kept doing all the stuff I was doing. And a year after that, or I guess 3 to 4 months prior to the next follow-up, I played soccer and my leg was fine. So I was like, okay, well, that's a really good sign. And then I went back and it was normal. There was no plaque in the artery, according to this ultrasound. Because I've had people tell me too that ultrasounds aren't that reliable, but I also had symptoms and the symptoms went away. So regardless of how reliable they are, and if it was 79% blocked or whatever, I had symptoms and then they weren't there. So I can run now. I mean, if I go up a mountain, I get some tightness in both calves, but it's nothing like what that was.
There's no asymmetry that you can detect at this point. Okay, well, regardless, the fact that, what was it, a year later that you got the second one that was 50% or less?
Yeah.
That's at the same site.
Mm-hmm.
So the, incorrect ultrasound theory would make more sense if there was only one.
Yeah.
Because of the fact that there was one that had high occlusion, then a successive one that had lower than the first one, and then a later one for which
there was none.
There was none.
Follow-up a year after that one also showed that it's still clean. So I've maintained it.
And now you have no symptoms.
No symptoms. Again, I get tightness in my calves because my calves are tight from both legs if I go up a mountain, I hike up a mountain, but that's nothing like what this was. This was excruciating pain because there's no blood to my leg, and it was the whole, from the knee down, everything. So
now before we get into your hypotheses, one obviously forms for mine right away, which is, is there possibly some kind of thing going on with you with clotting factors or anything along those lines that's distinctive to you for which you may have a greater susceptibility?
Potentially. I've never tested for anything. However, I feel like if that was the case, I wouldn't be able to do what I just did or what I have done. I don't know that it would have gone away. There's this clotting tissue in there, with LDL levels astronomically higher than what they say they should be. And without knowing if there's clotting factors, if there was though, would I have been able to get rid of those things? I don't know.
Well, present day experiments on animals, for example, use catheters intentionally, but balloon catheters to denude the coronary artery in a rodent to create atherosclerosis.
Mm-hmm. So
they literally are demonstrating the response to injury hypothesis themselves, right?
Yeah, that's interesting. I have things to say about that too. That's interesting. I didn't know.
But this is something I've always wondered about type 1 diabetics, because I do believe part of my larger theory on atherosclerosis is that we have a long list of things that cause the injury that also include, by the way, regular maintenance. Endothelial cells need to apoptose just like the rest of the cells too. And so you need the immune response to be able to handle that. The issue is that there needs to be a lower insulin environment in order to accomplish their closing hours housework. And because of that, if you're not prioritizing recovery, you can binge from either direction. You can binge in food because you're eating around the clock and therefore you're hyperinsulinemic all the time, because in a normal person, what do you see? You see those people are in the worst shape. Those people are waking up and having midnight snacks, that kind of thing. That gets dark pretty quickly. On the other end, I think that there is such a thing as overexercise. I think you can have a vascular injury and then hold up your immune response by pressing further. It's kind of like breaking your leg and then walking around on a broken leg. That's been my opinion for some time. The catch is that you don't feel a vascular injury unless it's pretty severe, and it's probably because there was something that caused the vascular injury along with other tissue damage.
Yeah.
But as far as like a tear, it's not, you don't have nerves that feed that back to you without there being more involved. So the urgency of your immune response to be able to direct itself to help fix that, to help set up the clot, etc., you're not aware that this is that moment you need to be careful. And that's very relevant, I think, to why I think somebody can be on the perfect diet, perfect protocol, whatever, for years, and then, this is my favorite analogy to bring in. Their buddy comes in from out of town who loves, who they knew in college, and he's like, let's do shots tonight. So you do shots all night, and then let's do a pizza at 2 a.m. What the hell? I mean, we used to do this all the time. And then next morning you go, now let's go ahead and you remember we used to be able to run 12 miles. I'll bet you I could still beat you. I think a scenario like I'm describing could actually set up an otherwise healthy individual for a coronary event. I'm not even kidding. And I think that that's why a lot of times you can see something like that if you have an unattended to, and by unattended, I mean you're outcompeting your immune response. That's my hypothesis.
Yeah, I think that is, I would agree with that as sort of an acute clotting situation. That's what it creates, right? I think that's what I got myself into. And there's a reason I think that it's that rather than a nervous system imbalance, which is the other mechanism of heart attacks. But what you described from those two friends, the nervous system imbalance response could also be relevant there too, because of what they're doing. And again, we'll get into that, I'm sure. So yeah. The other thing is that, so I got this reversal plaque in my leg, peripheral artery disease. I'm actually working on writing that up as a case study.
I was going to say, should publish.
You actually mentioned that to me, and that's why I'm doing it. So initially, you were the first one. So yeah. And then this year, back in February, I went and got a CT angiogram of my coronary arteries and did clearly analysis after that, which I'm curious as based on your video, what I saw and what you think about this. But yeah, they clearly showed that there was pretty much no plaque. That small amount in the RCA is still there, so I guess it hasn't progressed since the heart attack. The stent is patent. There's no clotting tissue downstream from the stent. And I was pretty happy with that. So I kind of got what you were saying as far as the clearly issues in that video. And so it is what it is. I was happy to get that result regardless of what it means. I feel good.
But I do want to zero in on what you just said.
Yeah.
So outside of the plaque that you already knew, the little bit of plaque that was in the RCA, and outside of the stent that was placed, which there's no getting around it, you're going to have plaque around that. There's no way that causes the damage. Was there any plaque in any other coronary artery?
According to clearly, no.
Okay.
Yeah. So yeah, that's what it said. And I could pull up that report. It's actually on my Instagram. It's been posted before. So.
I'll save you some time. Don't get me wrong. I think there's potentially some value that you could take it to heart flow. You could take it. You could also get a Q angio. Those are the 3 different quantitative measurements that we had. But if there's one thing that I've kind of come away from, that is sort of the value of the preposterous amount of expense and effort and work that we put into for this study, as to where I'm sitting right now, is that with all of these AI-guided readers, below a certain level, you've got the noise floor. You've got statistical noise. And there's a lot of very strong decisions being made on what I think is unfortunately more statistical noise than should warrant those hard decisions. So if you already have low plaque to the extent to where they can't even themselves determine there's an artifact that may or may not be a plaque, that's a pretty good scan. It's probably pretty likely. But again, it brings it back to the degree of occlusion you had is very mysterious to me, at least with regard to what you would typically expect for populations where there is an association of high LDL and plaque. Let me And let me set the table on what I'm saying on that for a second, because much of the studies that have an association between LDL and plaque formation have some kind of impairment with their lipid metabolism, either genetically or some kind of acquired disease, such as metabolic syndrome, which is typically just another form of insulin resistance syndrome, right? And truly, I have yet to see good studies that can show an association between LDL and the second case I was talking to you about like the runner who has like, say, a 2000 CAC and is shocked to find that out because they had no symptoms. It's almost all in the LAD. They have like, much more advanced coronary artery calcification all around that area. Those folks that I've seen thus far do not seem to have an association that at least obviously emerges in the same ways these other studies I'm describing. And that becomes very relevant because getting back to just the expectation in that first category of population for which there would be a high occlusion, I would expect a lot of plaque in other areas, and I would expect more calcification, generally speaking. Again, for that degree of occlusion, for getting up to 100%. You're either in one of those two buckets and you sound like you're in the second bucket, which has a lot less study behind it, which is just a shame because I wish we did. I wish that we got more information from whenever that appears.
Yeah. And as you're talking there, I think I can shed some light or some theories as into why marathon runners tend to have more plaque. And I think I can shed some light on why having higher calcified amounts of plaque or any plaque in there in general lead to higher rates of heart attack, because that's the most important question. You can see that the plaque there, and then you say, okay, that's there, and it associates with higher risk of heart attack. Why is the most important question. Because if you understand why, then you can understand an approach to maybe prevent that heart attack despite plaque. And that's what I really wanted to dig into because it was personal to me. It's like if there's plaque there, which before I got this imaging, I assumed there was, right? Because I had a heart attack and it's there. And even if they put the stent in there, I'm like, is it closing the stent? Is it more plaque coming in? So that's just where my head was at. So I had to figure that out. And yeah, so using this theory of structured water, and I think, from my perspective, I think that plaque has way more to do with blood flow dynamics than anything else. And there's some really interesting work of some scientists that people have pointed out to me, which people have been great. Like, I'm sure you experienced this too. Like, I start talking about this stuff and people have this information. Hey, you read this guy's work? And I go look at it and I'm like, this is amazing. Why didn't I know about this? Why does nobody know about this? But also Beraldi's work, Giorgio Beraldi, like his books are fascinating. And he was seen as a heretic. And I'm like, that's a guy you want to read. If he's finding evidence that's bucking the trend in cardiology and they shun him, you probably want to read that.
What's the book that you would recommend people read from him?
From Beraldi?
Yeah.
So I think the best one is The Idiopathogenesis of Coronary Artery Disease, a heretical model based on morphology is what it is. And it reads like a 200-page research paper. And in the end of that book, he puts forth his theory about heart attacks that happen with no blockage whatsoever, this nervous system imbalance. So it's originally where I got that. And since then, I found a lot more that supports it. And people have come to me, and if you look at just statistics in medicine, there's a large percentage of heart attacks that they go in and they find no blockage and people have heart tissue death. And even like that's Minoka's myocardial infarction with non-obstructive coronary artery. But then there's this whole percentage of STEMIs. Like there's one study that I think that was like they looked at 80,000 people and only 17,000 of those people who had an in-STEMI, which is the less serious form of heart attack or whatever is what they say. Only 17,000 of them had a blockage, which meant, and whatever that is, 63,000 other people, there wasn't one.
Tell us what a STEMI is, real quick.
Well, STEMI and in-STEMI, they're just looking at the EKG and they're looking at, basically how the heart is reacting to this, whatever's happening to it, right? So they see ST elevated myocardial infarction, that's STEMI, STEMI. And then in-STEMI is non-ST elevated myocardial infarction. So on an EKG, they're looking at is the ST segment on the EKG, which is, the little thing that you see for a heart thing.
Yeah, you're seeing this thing and it's this section.
Right, the section of it is elevated. Right. And so so when you look at that, or when they look at that, they see in STEMIs and there's someone's having heart attack symptoms and they see that it's not elevated, it's usually less severe, right? And then in STEMIs, it's usually more severe. Mine was a STEMI. it was more severe. So yeah, that's what they're talking about there. But in a certain percentage, so in most of the time in STEMIs, they find a blockage. In STEMIs, it seems that most of the time they don't, according to some literature that I read. Now, you may talk to an individual cardiologist that sees it differently. I don't know. But that's just kind of the categorization of things. And then there's like, it's estimated as like 8 to 20%, depending on what you read, that are MNOCAs, myocardial infarction with non-obstructive coronary artery. So there's a tissue dying for some other reason. And I think that Beraldi highlights this because of the discrepancies he saw when he was studying the hearts in the way that he did, as far as where a blockage was and where the heart tissue death was. There was discrepancy in these people. And he was like, well, that's interesting. And so
the blockage is in one place.
Yeah.
And this is the story we're usually told, right? It's the one I just described, that just downstream of that, presumably right downstream of where the lack of oxygen is where we would expect to see the cell death.
Right.
What you're telling me right now is that, no, that's part of what Beraldi was looking at?
Well, let's talk about Beraldi's work. It's so fascinating. So he developed that plastic cast model. He had the ability to cast the arterial system of something, he was doing on hearts, and he probably did it on thousands of hearts in his career. And so he invented that model. And the first thing he found was that any time, and it wasn't just sometimes, but any time there was a 60 or 70% narrowing of an artery, the body always built collateral arteries around it, or arteries from the RCA came over and fed the area that was like the arteries. Circulation came from somewhere else, right? And so
we should definitely unpack that. So you're talking neovascularization now. Right. You're talking, here's an artery, it's getting blockage. Now there's literally new vessels being built, like inside the heart. Again, getting back to the amazing aspects of the immune response, I think this actually makes use of macrophages a lot. Literally bypassing, making their own organic bypass.
Right.
It's really fascinating.
Like going like from this side of the blockage to that side of the blockage was one thing, or from another artery over here. Like if this tissue is starving for oxygen, this blood will come from this area over here. And he found that. And he also found that there was, like I said, a huge discrepancy between people over which artery supplied the most of the heart with blood. And it was varying all the different aspects. So like I said, I really don't know if the tissue area that died for me was just from the LAD. I don't know, because I don't know what my distribution is. I don't know if there's any way to tell that. You can tell if it's right or left coronary dominant, but I don't know if you can really tell. So anyways, he found that. And I've had people tell me that, some people have collateral, some people don't. But Beraldi's work, and again, thousands of hearts over his career, found that every single time, and he was very specific in his writing, any coronary occlusion that was over 60 or 70% narrowed always had collaterals. And which is interesting, right? So that right there gives us some clues as to why, if you look at the literature for elective stents and bypass surgeries, they don't prevent future heart attacks. Because if you've already got collaterals in there, like say that they do a heart cath, and they say, there's 80% blockage. Beraldi's work shows that that's got collaterals, right? And so if you go in there and you place a stent and open that up, does that really make a difference? If you go in there and you do a bypass with a vein, does that really make a difference if the body's already taken care of it? If it doesn't, then you're just as likely to have a heart attack because they haven't addressed the real cause of heart attacks, which is exactly what all the literature shows. And it's not very wishy-washy. It's very clear that bypass surgeries and elective stents, so stents placed when there's not a heart attack happening, are not very effective at preventing future heart attacks.
I have a guess. It's a hypothesis. I'd be willing to bet that they would be more effective in a very diseased population that's heading down really fast. So I think of some challenge cases in my own family who I worry that, given concerning level of disease, would they make strong lifestyle choices? And for which I don't have as strong a faith that they would. But that gets me back to the same issue as usual, which is we keep ending up in these situations where we're studying exactly those people.
Yeah.
And then coming up with the standard of care from those outcomes. Right. But getting back to why I have that guess is because the neovascularization still takes time.
Right? Well, so I found literature, 2 studies, and I haven't looked that hard. There's probably more, but I just found 2, one in dogs and one in pigs. So they're animal models. but they gradually induced a stenosis, 100% stenosis in the dogs in over 4 days, and the vasculature compensated and kept the animal alive.
Wait, 4 days for creating it, or 4 days for the neovascularization?
They created a stenosis over 4 days, and the body responded. So they created an artificial stenosis, and they narrowed it over 4 days until it was completely occluded, and the body built vasculature around it within 4 days. And the pig study, I think, is 7 days. They did it within 7 days.
Wow.
Yeah.
Wow.
So now there are things, I think, that can inhibit neovascularization or angiogenesis, like poor insulin signaling.
Right.
Growth and repair is what one of the things that insulin does. So if you can't grow things, then maybe that's why, insulin resistance, type 1 diabetes is so...
You need your immune response at the driver's wheel. That's the thing. And this is why, by the way, I do think type 1 diabetics are at higher risk, because that delicate, seesawing effect that the immune response is usually counting on, having the control over. I worry about that.
Yeah. So the other thing, as far as neurovascularization goes, is blood flow. Like adequate blood flow also stimulates the production of new vessels. And as we get talking into my theory of structured water, I think we're going to see why we're struggling so much with blood flow and why it's a big issue. And also, I think that the whole insulin resistance and type 2 diabetes thing, I think it's the end stage. It's the thing that basically the straw that breaks the camel's back. When you're that, and your body's having this whole response to, I would say, lack of infrared light, then that response happens. And if you're also insulin resistant, that's a real bad thing to be in that situation. And we can talk about why. But yeah, so Beraldi's work showed that collaterals happen pretty fast, and that they happen 100% of the time, according to his literature, if there's a 60 or 70% narrowing. So what he also found was that, like we've kind of alluded to, he would find that he studied people who died of heart attacks, who didn't die of heart attacks. He found blockages in people who've never had a heart attack, in their lifetime, but they died of something else, like a car accident or something like that. And he would find issues where they're like the tissue death was here, and the blockage that they had or that they thought caused things was over here, like in the RCA, and it was tissue happened in the LAD. The tissue death happened in the downstream from the LAD. So it's like this discrepancy here. How did this tissue die if there was never any blockage there?
But he does believe the two are related.
I don't think so.
Oh, okay. In other words, he's saying, hey, we're just looking for the tissue deaths and the blockage, and then assuming that there's a relationship.
Yeah, that's why his book is based on morphology. That's what he's looked at. He studied the morphology, and then he applied this theory of heart attacks, and he's just like, well, I don't know if this is making sense based on morphology, based on what I'm finding, as far as where the plaque is, where the tissue dies, and all this stuff based on collaterals. Yeah, and he found anywhere like the anastomotic index, anastomoses, meaning more blood vessels around it, was anywhere from, I think it was 16 to 33 different vessels that formed. And they're very, very small in many cases, which is why on an angiogram, you may not see them very distinctly, and I have these images and presentations that I've done from this guy named Knut Schroke, who was a doctor in Germany. And he was, he was putting contrast into coronary artery, and he was injecting the contrast, and you can see the video, and you can see that the contrast is here, but it's also down here, and there's nothing in the middle, right? And so then it keeps going, and you see the contrast come down, and you see the blockage. There's like a 95% blockage there. The blood is barely trickling through, but there was very contrast signal very distinctly over here, which means there has to be collaterals coming around, but they're so small that you can't see them on an angiogram because it's just so diluted,
Right. So it's because they're splitting out so much.
Yeah.
Gotcha.
Because, again, Beraldi found there are anywhere from 16 to 33 different vessels depending on the stenosis. So if there's 33 different ones that are going around, they're going to be very small, but they're fully compensating the heart with blood in many cases. And again, the more metabolically healthy we are and the more blood is moving properly, the more likely those collaterals are going to form. But even then, Beraldi found that 100% of the time they were there, and we have no idea about the lifestyles of the people that he was studying because he just didn't take that data. So I don't know. Maybe it's just something the body does really well, and we totally missed the boat on what causes heart attack. And then he offers a theory at the end of his book, and then I've looked into that more, and I found more literature to support it, this theory of heart attacks, which, again, I could argue that it's what happened to me. It could be what happened to me. The blockage could have had nothing to do with it.
So what's the theory?
Yeah. So there's, again, like we talked about, there's this subset of people that they find no coronary artery blockage, yet people are having heart tissue death. They're having a myocardial infarction. And there's this discrepancy about, how many in-STEMIs are that. So what happens is there's a few different things that I think that kind of set the stage for it, right? So there's metabolic dysfunction is one, because the heart really likes to burn fatty acids and ketones, as most organs do. But the heart preferentially burns fatty acids and ketones. Even in the presence of glucose, it will choose to burn fatty acids and ketones. So if we're already metabolically unhealthy, and that could throw that off a little bit, but it's more triggered by the nervous system. The second thing is inflammation and oxidative stress, whatever you want to call it. There's many different names for it. I like to say low body charge, because I think the body is all about just getting electrons into your environment or into your body, which is just energy. It's all energy dynamics. So low body charge. So inflammation, oxidative stress, which depletes nitric oxide. That's the key. And then the third thing is this imbalance in the stress response. So this basically means, everybody hears that we're in sympathetic or parasympathetic, but we're never really in one or the other. It's always both. We're just getting kind of a seesaw effect of what's happening. So if we get a stress response, we get a surge of sympathetic and a lesser surge of parasympathetic that kind of keeps things in check, right? So think of it, the analogy I give is if like you're walking your dog and the dog's on a leash and your dog sees your neighbor and goes for your neighbor. That's the stress response. The leash is the parasympathetic that holds it back from becoming something catastrophic like your dog attacking your neighbor and you get sued, right? So that's really important. We need that parasympathetic signaling to hold things in check, even when we have a stress response. And that's something that's unique to mammals. That's why we have two different pathways in the vagus nerve, which is also interesting. But anyways, so that happens. When that happens, if we get this gradual inhibition of parasympathetic, which is more common in type 1 diabetics because blood sugar regulation is never going to be as normal as someone who's not. So, but it could happen just in lifestyle in general, disrupted circadian rhythm, stressful job, whatever it may be, financial issues, all this stuff like that are leading to this we're more in the stress response all the time. And we kind of gradually inhibit this parasympathetic. And then we have this stressful event happen, which is pretty well known in medicine that heart attacks are associated with stressful events. Stressful times of the year, Mondays are more common. Monday mornings are the most common time for heart attacks. Sporting events, like high profile sporting events, people are betting lots of money, holidays, like all these things, daylight savings, when we shift the time, all these things are associated with higher events, heart attack rates, right? And so we get this surge of stress response without the lesser surge of parasympathetic. And the reason that's relevant as far as nitric oxide and inflammation and oxidative stress, and why we also see correlation between those things and heart attacks, is because when it comes to heart tissue, the nervous system signaling, the stress response goes in there just fine. But the non-stress response needs nitric oxide in order to enter the heart cells, heart tissue. So if you've got low nitric oxide because you've got poor endothelial health to begin with, and you're also just got this high amount of inflammation and oxidative stress, then it doesn't get in as well. And we get this surge of stress response without the break, without the leash of the parasympathetic. And what that does when you get that to heart tissue is it creates this stress response that's unchecked that causes the heart tissue to burn more glucose than it wants to, because that's what it does in stress. Like if I went for a run, my leg muscles start burning glycogen because we get that stress response and we start getting glycogen burning. And what does that do? It creates hydrogen ion and lactic acid buildup in that muscle, and we feel burn in the muscle. So when that happens in the heart, guess what we feel? Burn right there. So I don't think angina is restriction of blood flow in many cases. I think it's this imbalanced stress response signaling to the heart. If you look at the environment we're in and how it's imbalancing our nervous system, that's what can happen. Now, if that happens too extensively, like you get a stressful event, again, daylight savings, whatever it is, then that signal happens and it goes full blown, and we get this large amount of glucose burning, which the heart does not like to do. So if we're metabolically unhealthy, that's more likely to happen, I think. And so you get this glucose burning that happens, and that creates lactic acid, hydrogen ion buildup. And when that happens, it's been shown that like lactic acid production increases 8 times in that scenario, and we get this swelling. right? So this edema that happens in the tissue, and the swelling comes like this. Now the pressure is greater in the tissue coming out rather than the pressure usually being greater as blood coming in. And so we get this swelling there, and then the blood can't get in, and we get necrosis, right? There's no oxygen, no nutrients, and we get tissue death. And I've given presentations on it. Beraldi talks about it in his book, and there's all this citation that shows that this stuff happens, whether it's the interference of nitric oxide to get parasympathetic signaling in, whether it's the edema that happens that creates this, he calls it paradoxical bulging, like the tissue of the heart becomes swollen like that so that the blood can't get in, and we get tissue death. And then they go in there, and what if that happened to me? Like, what if that was what happened to me? And they went in there, and they're, oh, there's the blockage. That's what caused it. And it wasn't that at all. And so it's interesting. If you look at my angiogram, there's this picture of my angiogram where you see blood, right, coming in here, and then you see the blockage. You see the stenosis, and it's 100% blocked right there. But then there's blood on the other side of it. So there could be collaterals around that have grown around that, and they are supplying this here. But then you see when the arteries get smaller from the LAD, they're going into the tissue, and you see them, and they're kind of like, there's some blood in there, but it's like struggling to get in there. You know, it's kind of wispy. There's not thick blood in there. So if this tissue is starving for blood, and there's blood on this side of the stenosis, why is that not going into the tissue? Right? Why is the diffusion, like the tissue demand for oxygen, not so great that it's driving that blood flow into there? And, you know, I've had cardiologists tell me that's called a no flow phenomenon, where this happens sometimes. They'll go in and they'll put a stent and they'll open it, and the blood still doesn't flow. It still doesn't go through there. Why is that? If someone's having a heart attack and there's a blockage that's causing it, and they open it and it doesn't flow in, why? Maybe because there's too much pressure down here from tissue death that's happening in the other mechanism we just talked about, causing pressure here so that the blood can't flow into it. Does that make sense?
Yeah. So is this, let me see if I can follow this. Is the hypothesis at least opening up a possibility as there being tissue death ahead of an issue with the blood flow?
Or regardless of blood flow.
Regardless of blood flow.
Right. Whether it's happening or not, so like that blockage could have been there for me. Let's say that was there for 2 years before my heart attack, and the body built collaterals around it. Everything's working just fine. Right. Then I have this situation where I get into a stress response. We talked about what happened right before. I literally had the most stressful news of my life and couldn't figure it out, and then pushed myself to do that workout, and boom, I have a heart attack 20 minutes later. You know, maybe I sent my nervous system into that signaling, and then I have this stress response that caused the tissue death. They go in and they see, oh, there's the LAD, that's a blockage, but we have no idea how long that's been there, right? So they open it up, but they also gave me morphine at the same time. I don't know which one. Did the morphine calm my stress response and stop that damage from happening? Or did they open with the stent and restore blood flow? When you look at the angiogram, it's kind of interesting. There's blood here that's not flowing into there, even though this tissue is dying and starving for oxygen. Why is it not flowing?
So you think it's actually possible that, let's say you were at home and you had your own morphine supply, that it's possible you might have, not that you're making this claim,
right,
but you would say that it's not a 0% chance, given your present hypothesis, that had you been able to move things towards a parasympathetic context, that might have relieved your symptoms.
Potentially. Yeah.
Again, not that this is exactly what you're claiming.
Yeah, and not that it matters too much. Like, in that sense, I'm grateful that medicine was there, and whatever they did, I don't know what it was, whatever they did, I'm still here. You know, whether it was the stent opening up the artery or whether it was the morphine, I don't care. I'm still here. You know, and I tend to think that mine was more an acute blockage situation, which we'll talk about with structural waters we haven't even got to yet. But the reasons for that, I think that was the case because it was so immediate. Like, it was literally, I was fine, not fine. You know, so something happened immediate like that. Where, as I've talked to a lot of people who have had heart attacks, and they're like, yeah, you know, I felt so weird for a little, and I just kind of waited, and 3 days later, it still felt kind of weird. And my wife was like, let's just take you in, and like, oh yeah, you're having a heart attack. I think that's more along the lines of this nervous system issue. I think that can be, and it could be worse than that, but you hear that story a lot. Or they're like, yeah, I had some symptoms, and then I just kind of felt different, and then I felt fine, but I went 2 days later to the emergency room and they found troponin or something, which, you know, they said you had a heart attack. that was still elevated, which is not typical. But yeah, so
without question, any of my cardiologist friends, if they were here, would be going, hey, look, you have 100% blockage. That's got to get taken care of ASAP, especially if you've got symptoms. Interestingly, there's a proportion of, and I wouldn't say they're the majority, but there is now a number of cardiologists I've talked to who have, their opinion has shifted, where whatever the blockage, if you're asymptomatic, they don't feel the data is there to do a stent.
Mm-hmm. Yeah.
And that's more recent, that whether it's the neovascularization or whatever the reason, there doesn't seem to be a good enough case to be made, even if it looks bad, that there's a blockage.
Yeah.
But I don't know, with those, they're usually talking about like a 70% blockage. Could be even those folks would go 100% blockage, you got to do something.
Yeah.
But again, not being symptomatic up until the point that you were having that event.
Yeah, I know people with a CAC score of over 3,000 with like near complete blockages, never had heart disease symptoms, never had a heart attack.
Yeah.
It's interesting. Yeah, I've heard that too. Like I've had clients that come to me and say, yeah, my cardiologist doesn't want to do a stent because they just don't say that it's, even if it's a 70% blockage or something like that, they just no symptoms, whatever. And so like, I like to see that. That's cool. That means they're thinking and they're not all just bad, or just indoctrinated into this way of doing it and that's it. I like to see the curiosity and seeing that there's learning. And I have lots of cardiologist friends too at this point. But the other thing though is, because they do a stress test. That's what they do. They see the CAC score and then they say, let's do a stress test. Or if it's bad enough, they may even do a heart cath and go and look at stuff. And they do the stress test and the person has symptoms. And they assume that it's because the blockage that they saw on a CAC, it's bigger than what the CAC is showing, and that's restricting blood flow, and that's causing the chest pain. But exercise also creates a stress response. So if it's creating a stress response and causing the mechanism I just described, how do you know? You don't. And then you go and you place a stent, you think you fixed the problem. And lots of times that does relieve symptoms in people, for a while. I think I've heard cardiologists say about a year. It relieves the symptoms. So is that placebo? They got a stent. Oh, I can calm down now. My nervous system's rested. And then for about a year, and then it comes back. Why does it come back? Because they never fixed the issue in the first place. Whether it's plaque forming or the nervous system imbalance, they haven't addressed the first issue. They've just placed a stent. So there's nuance, based on what I'm finding. And so it's just interesting. And I talk about this stuff because I want those cardiologists that are more open to hear it, because that's interesting to me. I want to talk to them. I want to see what they think, because I'm not a cardiologist. I don't know the ins and outs of cardiology, which I think is my advantage, which I think you think is also your advantage too, of not being in this and being able to look at things from this perspective and just go and see what you find without this preconceived idea in your head.
All right, let's talk fourth phase water.
Yeah.
Why is it called fourth phase? That's probably what we should kick it off with.
Yeah, so the first thing we'll talk about is what is structural water, what is fourth phase water, what is exclusion zone water. It's got many names, bound water. And the reason it has many names is because of its properties, but also because many different scientists have come across this phenomena over the years. They just called it different things. So they call it different things in the literature. But Gerald Pollack has made it the most notable. As of recent, he wrote a book called The Fourth Phase of Water. He's a scientist up at University of Washington. But people write him off and say, he's the only one talking about it. It's like, no. Gilbert Ling, Albert St. Georgi, Fritz Albert Popp, like Mei-Wan Ho, all these scientists over the last 100 years have been talking about it. And Albert St. Georgi won the Nobel Prize. He's a notable scientist. So anyways, what is it? So it turns out that water has the ability to hold energy, which makes sense. We're on a water planet. We are basically a water planet fueled by the sun. And when water holds energy, it can actually, what they say, structure itself into a different form that's not ice, not water, and not steam. So there's a fourth phase, right? And this phase is more like a gel. So you can think of it like the consistency of raw egg white or Jell-O, or when you put your bone broth in the fridge and it's got good gelatin, it'll make a gel, right? And so the way it specifically forms is water is, an oxygen and two hydrogens. And when water holds energy and it gets next to a water-loving surface, which all biological surfaces are water-loving, a hydrophilic surface, then what happens is one of the hydrogens gets cleaved off and you're left with an oxygen and a hydrogen. And those oxygens and hydrogens team up with other oxygens and hydrogens, and they kind of form this lattice-like structure, this hexagonal-like structure that, links to itself, and we get this planar-like structure of hexagonal, like water formation. And those can stack up on each other. And when they stack up, like if my hand here is a hydrophilic surface, they get stacked up on each other, and this layer here is more like a gel. And it's actually not H2O. The molecular makeup is, they say, is H3O2, just because of how that's made up. And so that gel is present in a large amount in the body, or it should be, at least, if we have the right conditions, right? So that's the reason I feel like a gel. Most of the water in our cells is in this form. Not all of it, but most of it, which is why I feel like you literally just move it and it bounces right back. And so it occurs in cells, but then there's also places where there's liquid water in the body, like in blood, cerebral spinal fluid, lymphatic fluid, there's liquid water. But on the surfaces that the liquid water is next to that are hydrophilic, like the lining of an artery, we get structured water there, because it's if we have the right conditions, which means we have the right energy to the system. And they've shown that this is the case. So if people go into PubMed, they just type in cell-free layer. Many articles will pop up that are not even Gerald Pollack. Just many authors have found
cell-free layer.
Cell-free layer. And I'll explain why it's called cell-free layer in a minute. But there's this layer next on the artery wall that red blood cells don't get to. And they call it a cell-free layer because they can't get to it. The reason that is because one of the nicknames of structured water is exclusion zone water. Because when it forms, the way that it forms, like those hexagonal planar things that are lined up, they kind of line up offset, which makes for a very small space. So nothing can really penetrate structured water. And Dr. Pollack has shown this over and over again. They put things in the water and they build structured water on the thing, and it pushes all the things in the water over to the side. It excludes them. So when you have something there with structured water, almost nothing can penetrate it. And that's why it's called exclusion zone. And so the scientists were looking at this stuff and they're like, oh, here's this cell-free layer. The red blood cells aren't going there. They can't touch the lining of the artery. So what Dr. Pollack found is he started measuring things, and he said that even the protein albumin couldn't penetrate structured water. And it turns out what can penetrate structured water are only small hydrated ions of minerals that are potassium or smaller. Anything sodium or bigger, because there's this kind of, when you hydrate minerals, there's this size chart, right? So sodium, potassium is the cutoff. Anything sodium or bigger can't penetrate it. Potassium or smaller can. And that the little space there is big enough for potassium to get in, and also nitrate ion, which is nitric oxide. Makes sense. It can come in and out because that's where we get it from the lining of the artery. And so it protects the lining of the artery. So if you look at things that are bigger than albumin's, from what I found, 3.8 nanometers in diameter. And HDL is like, I think 7 to 12 nanometers. So much bigger.
Oh, yeah.
Correct. And LDL is, I think, in the 20s. I remember exactly. I have it on a slide somewhere. But all those things are way too big. If there's structured water there, according to this literature, the lipids will never touch the lining of the artery.
So let me try to create a visualization for people. The top here, I'm looking at my camera so I know, we're going to say is what is commonly referred to as the lumen. That's the inside of the tube that is a vessel, right? And you've got the blood flow going through. Now the blood is water-based. Down here is what is the cell that lines our vessel walls, known as an endothelial cell. And what is often described is everything, all of the cells, including the particles, especially lipoproteins, they're constantly bouncing off of endothelial cells, especially if it's like going towards a shear space, like if it's going towards a curvature or a bifurcation, they're just smacking into those endothelial cell walls. Granted, the endothelial cell walls themselves are 5 to 10 nanometers thick. We haven't gotten into glycocalyx yet, but there's some other things on the surface. But the point is, how much are they actually literally touching the surface? And what you're telling us is they're not touching, because there's almost like a force field of sorts, this gel-like fourth phase water that creates a barrier such that it excludes out what the contents of the bloodstream is. Is that a fair representation?
If we have a healthy layer, yes, then that's what's happening, right? So it's not like it's just there automatically and it's going to be there forever. We have to be under the right conditions. And when you learn that and you understand what the right conditions are, I think it explains why, as a society, we're dealing with atherosclerosis as a whole. And it's partly because of insulin resistance, but I think that's the end stage thing, which we'll get there. But yes, yeah, if that's there, according to this science, the lipids will never touch. Nothing in the artery will ever touch the lining of the artery. Nothing in the blood will. And you mentioned glycocalyx, and lots of people describe the glycocalyx as this anticoagulant gel layer because glycocalyx is providing surface area, and that's what it needs. The structured water needs a surface, a hydrophilic surface. So we need more surface area. That's why the glycocalyx is there, to create the surface area so the structured water forms on it, and it creates this gel-like barrier. And
So just for the visualization for people, I like to refer to glycocalyx as like the fur of the
shag carpet.
Yeah, it is. Shag carpet's a great way of describing it. It's these stalks, if you will, that extend out, but they point in the direction of the flow. So if the blood's going this way, they point that way and they're slick. Mm-hmm. That's been kind of the expectation up until this point, that they also are protective in that regard. What you're saying is they're in the same space as the glycocalyx and seem to be partners with it. Sounds like, right? Like they're interwoven between each other to help create that barrier.
Right. The glycocalyx provides the surface area. Like when you have that shag carpet, it increases surface area so that more structured water can form. So glycocalyx is the surface area provided for that, so that when and the shag carpet, it's flowing this way like that. But that's because the structured water provides the slick surface, because that's another property of structured water, is it's frictionless.
Now the glycocalyx, this has been known for a long time, has a health to it. Yeah. You can have poor glycocalyx health, which usually associates with worse cardiovascular health.
Mm-hmm. Yeah, and I would argue that what we're really talking about here is structured water health. And that glycocalyx is just the mechanism, the surface area, again, for structured water to form. When you damage structured water, which we'll talk about how we do that, then you're going to ultimately then damage glycocalyx and then damage the endothelial lining. But all that has to happen first before anything's ever going to touch that endothelial cell, right?
Yes, although an important caveat, cells also have receptors. I assume in this hypothesis you're talking about, the receptors extend out past the barrier of the structured water. Oh, no.
Because so nitric oxide produced from endothelial cells, remember, it's small enough. Hydrated nitric oxide is small enough that it can penetrate structured water, so it can come out that way and into the bloodstream. Everything else that the cell needs and gets comes from the vasorum. It comes the other way.
Oh, we're going to have a difference of opinion.
That's okay.
Okay.
Yeah. That's what I believe.
I believe the receptors on the surface of the endothelium are pulling things from the, including VLDL is, a major focus of mine, but they're pulling lots of different nutrients and so forth from the lumen. Make no mistake, I think there's also lots that's getting delivered from the vasorum. Mm-hmm. And sorry, for all the visualization I just did, I know we probably lost a bunch of people, but the vasorum you could think of as sort of the teensy tiny vessels underneath those endothelial cells. They carry much smaller objects, I guess I can say, that the cells need as well. And that's kind of what you're referring to.
Yeah.
But
yeah, so the vasorum are like the blood vessels that supply the lining of the blood vessels, is what I would describe them as. So they come around the other way. So like people think like the endothelial cells here, I would argue that the nutrients and oxygen, whatever is in the blood that these cells need, doesn't come from the lumen. It comes from them. That's what I would argue, because if structured water is there, nothing can penetrate it. Like nothing can. It can't. Now, if there's a receptor that's like comes through there, that could be possible. I don't know. But I doubt it, because of the way structured water is. Like that's just what it does. And that's what Dr. Pollack has found over and over and over again, is that it excludes things. And so the cells have to be, and that's, I mean, I'm sure you're familiar with Sabotin.
Oh yeah.
And like
the outside in hypothesis.
Yeah. And how something that stimulates the growth of these endothelial cells is what starts the whole process, the whole thing. But if the structured water is there, nothing's going to damage them. And so there's other properties of structured water. Let's get into those first two. One, it's very electronegatively charged for two reasons. One, because water is a balanced molecule. You take one of the hydrogens away and you've got this bigger oxygen molecule that's negatively charged. It's not balanced by two hydrogens now. It's just got the one. And so the makeup makes it very electronegatively charged. The other thing is that when the molecules team up like that and they're linked together now in this lattice-like structure, that's these hexagonal planar things, electrons can travel through that now. They can travel through that. And so that makes it a very electronegatively charged thing too. And so earlier when I alluded to how we're basically just trying to gain electrons from our environment, one of those is through metabolism, but also from sunlight exposure, from direct contact with the earth, we absorb electrons. And when you do these things, the energy storage form of the body is structured water. And so when you put your body in that environment, structured water builds. So what is the main thing that Dr. Pollack has found in his laboratory that builds structured water? Infrared light. Why does that make sense? Because anytime the sun is up, it's 40 to 50% infrared light at all times. Again, we're on a water planet charged by the sun. That's the name of light, right? We try and gain energy from the environment and use it to create order. If we can't do that, we get disease, we get disorder. And so, it's very electronegatively charged. The other thing is, relevant to our earlier conversation when we talked about heart failure, is that they've also shown that the way structured water forms, because it's a very electronegatively charged area, and the hydrogens that are cleaved off are lined up next to it in the lumen of the artery or in whatever model you're using, there's a negative charge next to a positive charge, high concentrations. That's a battery, right? We know that. We look at a battery, we see a positive and negative charge. They've actually shown in Dr. Pollack's lab that you can put an electrode into the negative side of structured water and into the hydrogen side of the positive and power a light bulb. So it creates energy. Like I said, we are
conduit.
Yeah, we are batteries. We are basically structured water batteries charged by the sun. All life is.
Well, this isn't a hard sell for me in that I already have and have had for a long time a hypothesis that pretty much most of the things where, hey, this vitamin gives us more of X, I find that there's this large, okay, here's a great example. EPA is having a big day right now for its benefit to cardiovascular disease for a number of these disease populations. And they have a, pharmaceutical grade EPA, but EPA is omega-3 that we've already had in our diet this entire time. But why? Why does it have such a demonstrable benefit to this population that, for example, is hypertriglyceridemic? And I would argue it's because it's probably meeting an existing deficiency. So in the case of virtually anything for which there seems to be a benefit to the general population, my first instinct isn't, oh, that must be because that thing has unique properties such that it benefits us at an ever-increasing rate. The more you have, the better things are. Actually, no, I'm usually starting with the assumption that it's meeting the adequacy we needed. There was a deficiency in the first place. Infrared light, that's an easy sell to me that we, as a Western population, especially, have so little of, in spite of what our ancestors were built off of, right? Like they were getting way more sunlight than we were.
Yeah, even then, if you're sitting in the shade, infrared light is reflecting off the grass and all the bushes just right onto you.
Right.
And all life on this planet is outside in infrared light 24 hours, well, not 24, when the sun's up, right? And we're not.
Yes.
If you look at the surveys, the data shows that the average American is spending 93% of their time either indoors or in an enclosed vehicle today. So that being said, if we ask ourselves, if we acknowledge that structured water helps protect the arteries, and what builds structured water the best is infrared light, and we're devoid of infrared light, we're taking away our arteries' protection, right?
Yeah.
Then we added a bunch of insults. What have we done in the last 100 years since heart disease was a thing? We're adding in a bunch of toxin exposures. We're adding in a bunch of processed food diet type things. So now without the protection, we add the insults, right? We add the plastics and the heavy metals, and all the things that have been shown, the long list of things that have been shown to damage the artery, right? Then when we get that damage, whatever happens after that point, I think it has more to do with Subbotin's theory and that kind of stuff. It could just be it happening right there, the endothelial lining, like the damage happens. And then if we undermine the body's ability to heal that damage because we're insulin resistant, or our circadian rhythm is disrupted, which is huge for signaling for growth and healing and things like that, which is another big light issue that's going on, then the body has no chance. Of course, we had this epidemic of vascular disease because we've taken away the protection, we've added insults, and we've interfered with the repair. And we get this response. Now, the question is, which we've already talked about, does that response lead to heart attacks? Does that growth of plaque, are we barking up the wrong tree as far as the plaque? Or does the body compensate for that and we haven't addressed the issue, which is an acute clot and the nervous system imbalance? Like, that's this whole thing that I've had to kind of put together. But that brings me straight to the other property of structured water, in that it creates flow. So when I talk about that battery that it creates, this energy that it creates, they've shown in Dr. Pollack's lab, they take a tub of water and they put a tube made of a hydrophilic substance in the water. They add infrared light lamps to the water, and the water starts flowing through the tube with no pump acting on it whatsoever. So this energy gradient that happens does the work of moving fluid. And when it starts moving in a certain direction, it keeps moving. Now,
so an analogy I think we could pull out is like an electromagnetic rail, if you will, right? So the trains that can actually kind of float a little bit, but that's how it's done. Is they have an exclusion zone, right?
Yeah.
But it allows for there to be no friction.
Exactly. Yeah, and without that friction, it just starts moving, right? And so they've actually done this in an animal model, in a chick embryo model. They stop the heart of the chick embryo. Sorry for the animal lovers, but they stop the heart of the chick embryo. And at first, the blood kind of is like, it's like, what is it doing? It doesn't know what to do without the changes in pressure from the heart contracting. But then it figures it out, and the blood keeps moving. And they showed this back in the 40s. There's this guy named Thompson who did these studies, and there's other Dutch guy, I'm not even going to attempt his name. His first name's Leon, but this last name I don't know. Anyways, they showed they observed these things where they stopped the heart of dogs and the blood continued to flow. They injected tracers, and then they thought, well, they were insufflating the lungs to track the oxygen and make sure the oxygenation level stayed the same to see if it was circulating, and it wasn't. And they're like, well, maybe it was the insufflation of the lung that kept the blood moving, so they didn't do that. They injected a tracer, and for up to 2 hours after they stopped the heart of the dog, the blood was moving on its own. But eventually, that dog loses its energy. It's not, unless it was out in the sun, it wouldn't do that. It wouldn't keep moving, right? So then a researcher, graduate student, Dr. Pollack's, sent me these videos of this work, his experiments that he did. And they stopped the heart of the chick embryo, the blood kept moving, and when they put infrared light on it, the blood flow increased 300%.
Really? Wow.
Yeah.
Okay.
So it's a big deal. So when I talk about heart failure and they're blaming the heart for not moving the blood, this is why infrared sauna has been so useful, like the studies, mostly out of Japan, where it's so useful for heart failure. Because if the heart is not functioning, even if it was the heart's fault, if we take pressure off the heart by moving blood in other ways, then it doesn't have to work that hard. And they've seen like increases in ejection fraction. They've seen the heart go back to normal size in some of these studies when they use infrared sauna, which is why I got an infrared sauna. And then you also look at the structured water on the lining of the artery and how it serves this protective role. I learned that later. I didn't know that's what I was doing when I started this, but I found that later, or I put that together later. I just knew that it was creating blood flow when I talked to you before, that it was there and it's creating blood flow. And then I found that atherosclerosis has a lot to do with blood flow. And I found these researchers. There's one guy named Mayer Texton, super cool name, and another guy named Richard Thoma, who Subbotin talks a lot about, because Richard Thoma's work's mostly in German. Subbotin translated it. And basically both of those guys found that if you create either blood that's like too stagnant, not moving enough, or not moving too fast, then the body you can develop atherosclerosis. In dog models, they did this. They just changed the flow and they developed atherosclerosis. Now, I would argue that that's because, one, if blood's too stagnant, or if it's moving too fast, like Mayer Texton argues that we need to have this Goldilocks amount of lateral pressure. on the endothelial cells, like pushing into the structural water into the arterials. They need to feel that pressure. If they don't, so if it's stagnant, the blood's not moving enough, then the endothelials will start to grow in to create this less surface area or whatever. Just kind of like you put your thumb over the end of a water hose and it comes out faster. If the blood's not moving fast enough, there's vasoconstriction of the blood vessels because of the muscles in there, but also the endothelial cells will start to grow in. So that's one case. Also, if it's moving too fast, there's not enough lateral pressure. It's going too fast, which is why marathoners who spend a lot of time with their blood moving fast will also get the response. They'll get this response of the endothelial cells growing in like that. Then one day they go in for a CAC score after 50 years of marathoning, and they're like, why is it so high? Because you've created that blood flow that's too fast, and that's created this response of the way Sabot describes it is when the endothelial cells start to grow in to create the lateral pressure, then the vasorum have to grow in to supply those new cells. And when they grow in, they're not whole. Like they're just like, and it's like building a house and the windows and doors aren't in yet, right? There's this time where the blood can leak out. And guess where it leaks out? Right into the intimal layer, right? And it's when it leaks out of a tube, now it's stagnant. What does stagnant blood do? Clots. We get this clotting material right in the intimal layer. And that's more likely to happen if you're not very insulin sensitive. Because if you're not insulin sensitive, then those blood vessels don't form as well as they could. They take longer to form. We get more leakage. We get more plaque, right? And then if it's been there long enough, it will calcify. And then the other issue is now, like, because when you look at plaque, it's forming in the middle of the artery here, first at least. It's forming in the intimal layer and it's expanding. You can see that on clearly, right?
There's some debate on that. There's let's do this because we've been sort of bouncing around Sabaton. We should kind of give a little intro on that. This will be a podcast where we cover all the theories of atherosclerosis. So I mentioned the outside in. There's already lots of talks on this. I'm going to do my best to keep it from getting too technical.
Yeah.
But going back to my visualization, I'm looking at the camera again. We've got the lumen again. We've got the endothelial cells. And then there's so many different ways to break down what the tissue is below here. We're kind of loosely just saying subintimal space, right? There's actually multiple types of layers and a lot of things to discuss there. But importantly, subintimal space is where you could say the atherosclerosis appears. And then this is an observation that Sabaton introduced that was new to me at the time that I was reading it from him, which is that what's usually described is that this is one layer of endothelial cells, exactly one cell layer thick. They're long and they look almost like shingles if you're doing a cross section. What he said is, no, actually, they may start that way when you're really young, but they ultimately thicken to extra additional endothelial cells. And this is referred to DIT or diffuse intimal thickening. Okay, now down below in the subintimal space, there are these teensy tiny vessels. I mean, much, much smaller than the lumen that's above. And like I said, smaller molecules and macromolecules are going in through there and can help supply nutrients to the endothelial cells. And to be sure, I don't know, what fits, what doesn't fit, but most of those kinds of things, like you were talking about albumin, for example, I think albumin fits there as well. And I believe that certain sizes, I don't know how up the sizes go, of ApoB containing lipoproteins can fit there. And the staining that he was showing these cross sections with staining. He was pointing out how there are what appears to be a collection of ApoB containing lipoproteins. I think he was specifying LDL. We don't know for sure, but that they seem to be accumulating down low and then slowly moving up until you see the atheroma appear up here. Mm-hmm. So in other words, suggesting that indeed the origin of atherosclerosis is near the vasorum and that some kind of disruption or infarct or something like that, where it creates a problem here, is where we end up with those problems that appear up here. Mm-hmm. Right. Correct me. This is like me kind of going back from memory. I want to say like 5-6 years, but that's the gist. Would you say?
Yeah. And I would just point out that what he's saying is that it starts with a response of the endothelia something causes a proliferative response that causes the vasorum to make these changes and grow new things, and it causes whatever's happening in the subintimal space.
Right.
Right. So that could be these changes in blood flow, like Richard Thoma and Mayor Texan highlight. It could also be injury, right?
Yes. Now, here's where we're going to go. We're going to wrap in what has been more widely accepted since 2020, the same EAS group that gave us the famous 2017 low-density lipoproteins cause atherosclerosis, the 3-line graph that we all are very familiar with. Mm-hmm. They had a second paper that was in the works from the beginning that was a mechanisms paper. And that ended up shifting the whole field, or I should say the major voices in the field of lipidology, to more broadly agree that actually transcytosis is the major contributor to ApoB lipoproteins in the subintimal space. And that was a huge shift because literally all this time, it's been assumed it's a passive process by how they get in there, that they are smashing into the endothelial walls or that they're getting through the junction gaps. And this isn't to say that they aren't getting through the junction gaps, which we can get into a little bit later. But I've long believed, long before that 2020 paper was published, and I have tweets, I've got receipts of where I was saying transcytosis is how, I think I literally said, we can't crack open the book of atherosclerosis until we're looking at transcytosis. That's relevant when talking about the Sabatin work, because do I think those LDL particles there in the subintimal space, there's a strong case to be made that they were literally put there by the endothelial cells above. Yes, not only yes, but now that same 2020 paper I'm talking about, and lots of research since, shows that inflamed endothelial cells express more receptors such as SRB1, which transcytose LDL particles down, which incidentally, to me, should have been one of those moments where, and I don't want to sound too strong here, but I'm just going to say it, the field of lipidology should have slowed down for a sec and said, wait a second, this is a planned process. This is literally part of the playbook of inflammation at an endothelial cell level. Why don't we start looking a bit closer as to what that is? It definitely threw a lot, I think, objectively. It throws more support towards the response to injury hypothesis at a minimum, and makes it even more incumbent that you be able to disentangle whether or not there is an injury or some inflammation of the endothelial cell as relevant toward the development of atherosclerosis where it appears. Because right now, there's still a push that there is a response to injury. We agree. It's not mutually exclusive of the response to retention hypothesis, which I would agree with. They don't have to be. But in order to stand on the response to retention hypothesis, you ideally want to get a population of people with sky-high LDL, but who are not chronically inflamed, ideally, as a good test ground, right? And so that's why it was a big deal to me that came around. Well, so this comes back to the relevance of the vasorum and Sabatin's work. Again, I like all of the hypotheses. I like to chat about all of them. But once I saw that inflamed endothelial cells did this increased level of transcytosis, that then put the same requirement on Sabatin. Mm-hmm. How do you disentangle the injured endothelial cells? And I think he had a version of response to injury effectively, in that it's not diffuse. It's not all across because that was always going to be a problem with the response to retention, is you would expect that there would be a distribution that's a lot more predictable.
Right.
But no, there isn't. To be fair, and I want to be as fair as I can to those who are response to retention enthusiasts, I'm sure they would agree that, or I'm sure they would say, look, there also is mechanical stress, hemodynamics, those sorts of things are contributors. Mm-hmm. But do we see a wider Gaussian distribution of plaque as we would expect to see with the response to retention? Not to a level that convinces me at this point.
Yeah, and I think that things can end up in the subintimal space in that way too. I would just take it even further than that. Like, before that can happen, you have to have destruction of structured water. You have to have...
Possibly.
You have to get rid of it, like, because otherwise nothing can penetrate it. There's no transcytosis happening until that damage happens and they send out signals, more receptors, and say, hey, we need help.
That I'm pretty sure you're wrong on. This is I love the structured water hypothesis, but I'm very, very confident, let's just say, that there is receptor-mediated capture of things from the lumen by endothelial cells. And definitely one of those is what I just described, transcytosis of lipoproteins from the lumen into the subintimal space.
In a normal, healthy person.
In a normal, healthy person. I said that it...
Define healthy.
Yeah, well, no. I said that damaged endothelial cells upregulate things like SRB1.
Mm-hmm.
But under normal conditions, SRB1 does still capture ApoB lipoproteins.
From where?
From the lumen.
We know from the lumen for sure.
Yes. Like, in other words, let's say that I took a biopsy of, your cellular matter, and I looked inside these cells, the endothelial cells of a portion of tissue where I pulled and I looked at all of them, and I then checked out the mRNA, right? So I could actually see the transcription, etc. I'm pretty confident that I would find that SRB1 was in production, and possibly even see existing receptors, and possibly even see existing vesicles.
However, you just took that tissue out of its natural environment.
True, but I'm
so I don't think you can say that, because that's an injury. You just caused an injury. You just rocked that cell's world.
Okay, fair enough. Let's say if I cultured cells, right? I'll bet it. That's granted, and I want to be clear.
Mm-hmm.
I know that there are in vitro studies that I'd read with regard to SRB1, and it is still an emerging field. And I'll be upfront that in vitro could, be more induced and is not as reliable as in vivo.
Mm-hmm.
But all that said, I would bet you.
Yeah.
And for that matter, there's kind of a larger structural. I'm gonna get off on a tiny tangent. I think in the case of lean mass hyperresponders, there's a greater degree of transcytosis by endothelial cells to meet structural demands. So, for example, how adipocytes grow and contract, right? Contract, I shouldn't be used. I should just say shrink. But in particular, they need to increase their surface area at a point where there's storage. A lot of that's just even routine storage, just tiny bits. But where do they get that surface area? Like free cholesterol and phospholipids. I believe that there's a certain degree of it that's made use of by existing ApoB lipoproteins. Now, could they all be supplied by the vasorum? Maybe. But then why would they make these receptors for transcytosis and endocytosis in this case, which is where they literally ingest it and then make use of them?
Yeah.
We'll see.
I mean, we'll agree to disagree. I mean, I think it all comes from the vasorum, because it doesn't make sense to me that things would have to slow down enough to be transcytosed. Like the purpose of moving blood through an artery is to keep it moving. And when it doesn't move very well, we get issues, right? Stagnant blood creates issues.
That comes back to the mass. So in the case of ApoB lipoproteins, they're relatively small. They're easy to snag in a receptor like an LDL receptor. Now, when you do get to something like a monocyte, that's a whole different story. It's got a lot more mass, so you have to use things like VCAM. That's for lack of a better way of putting it, that's the cell walls version of speed bumps. It's like slowing it down and then grabbing it and then pulling it into the junction gap so that it can differentiate into a macrophage. Those are definitely not coming through the vasorum. Like I said, I don't know the lumen size of the vasorum, but monocytes are not flowing through there. That much I'm sure of.
Sure. And if structured water exists, none of that's happening.
I think it's possible that you may find out after this podcast that I'm right, but that doesn't disqualify the structured water.
Sure.
Concept.
I mean, how do we know anything's for certain? We just keep asking questions. Yeah, I mean, it's all fun to ask. I would just argue that when you look at, to me, it's like all that literature, and this is, people aren't going to like this at all, like especially people who are just research junkies. I don't think it's ever going to come. The answer is never going to come from research because there's so much nuance. There's so much things we think we know, or even the ways that we're studying it that we think we know that is telling us that. Which, like I said, you take something out of a host, you can't really rely on anything in there because you've taken it out of its natural environment. We don't know that it's going to behave the same way. So I could argue against all research that it's really only giving us insight but never giving us the answer. So when I find literature that suggests certain things, like that's interesting, but I am much more inclined to put my faith in the way that it's been for humans forever until we started having disease, or at least in these quantities that especially heart disease. Like 100 years ago wasn't that big of an issue. Well, 120 years ago wasn't that big of an issue, right? So what changed? Infrared light, toxin exposures, epidemic of diabetes. Like those are the things. Regardless of the mechanisms, those are the things. And then we do those things. I did those things and look what happened, right? And I'm an N of 1. But they told me that was impossible. People like you were even impressed with that result happened. And you've seen a lot of people do a lot of cool things.
You're talking, like, which one are you talking about? You're talking about the
reversal of PAD.
Oh, right. Yeah.
Like up to 99%, quote unquote, 99% blockage gone.
No,
interesting.
It's great.
That's awesome. And all I can do is be happy about it.
I mean, I doubt that I would have been that different from what you did. You were immediately researching and heading in the direction of what might be more, typical of ancestral baselines, which is already a position I kind of have. It's funny because I came into keto not from paleo because I wasn't in nutrition at that time, but I've always leaned a bit more in the direction of not that paleo is the way per se, but from an engineering perspective, I'm always thinking of things in terms of what's the evolution, literally, of our human operating system. Okay, so what were those core components? And is it a safe bet that how our ancestors were living coming up until this point probably had a lot of key components in common to look for that we're missing now, being relevant towards modern day disease?
Yeah.
So that's why I've had a number of people on who are not necessarily even pro low carb, but who we've had a lot of agreement on, a lot of the ancestral and whole food, for example, direction.
Yeah, sure.
Things like what you're talking about, I could see if I had an event, I would probably prioritize myself. Infrared light makes sense to me. Grounding makes sense to me, which we should mention for people who don't know what the heck we're talking about.
Yeah.
Literally taking your shoes, socks off, and you know how they say touch grass? Go out and touch grass.
Mm-hmm.
No, for real. Go out and touch grass, right?
Or the leaves of a tree.
Or the leaves of a tree.
Yeah, you're grounded. Yeah, definitely. Yeah, and that's just kind of, I think there's an inherent wisdom in that, which is something that I don't think science will ever give us. Science is super interesting. I read a lot of it, obviously. It's just, it'll never give us that. And I mean, everything down to like the fact that in the 50s, we invented fluorescent light. Before then, we had incandescent, which guess what? Gave off a lot of infrared. And then we had fire, which also gives off infrared. And we had sun. And then we had that switch. In the 50s is when it exploded. Heart disease exploded. We just lived indoors with fluorescent, and then eventually LEDs came along, which are very high in blue and very low in infrared. So it's just, that all matches up. And there's more components to it, obviously, many more. But that's a huge component of it. And I think it gets missed, especially in metabolic crowds where we're talking about insulin levels and diet and that kind of stuff. Like that stuff's important too. But we're missing this thing that was a huge component of our lives and is still a huge component of all life that lives outside all the time's lives. And the other thing is contact with the earth. Like all life on this planet is outside in contact with the earth 24/7. And we are not, right? That's something we have to account for. And so they've shown that if my feet are barefoot on the earth, my toes are 200 volts more negative than my nose or my head because I'm soaking in electrons through my feet. And those are free electrons. And the reason they're there is because the earth is a huge store of electrons because it's all coming from the sun. All energy for life on this planet comes from the sun in various ways. So, and I'm talking about electrons. So the sun is concentrating energy into the ionosphere. And when the ionosphere gets excited, like in a thunderstorm, it discharges through lightning into the earth. And that deposits electricity into the earth. And that's happening 1,000 times per second as we speak. And then we go contact the earth, and energy that's more concentrated will flow into an area of less concentration. I'm never going to be as concentrated as the earth, so it flows into me. And they've got some pretty cool things where there's studies that show that. So if you put together the fact that structured water is electronegatively charged, and that it's on all biological surfaces, which red blood cells are biological surfaces, and they found this zeta potential around the red blood cells. They found this negative charge around the red blood cell. It's an assumption, but the assumption is that is structured water. That's what's giving it that negative charge. That's what holds the charge, structured water. And so there's pretty eloquent studies where they ground people, and then they look at their zeta potential. They look at either live blood analysis and look at rouleau formation or aggregation of red blood cells, and they go ground them, and it's all evenly dispersed. Because if you have red blood cells that are holding a negative charge, like charges repel each other. So they don't like to stick together. So they get too close, they're like little bumper boats. Whereas if you lose that charge, you get agglutination, you get rouleau formation, you get these red blood cells that are clumping together, which makes it much more likely we get a clotting response. So there's just another aspect of infrared light grounding being in a natural environment that we're missing that helps us prevent clotting responses, which I think is more relevant in heart attack situations. Like for me, I wasn't getting sunlight. I wasn't grounding. I was also dehydrated. I was dealing with the constipation. And did that cause this immediate clotting response, like in an area that has like the most turbulence in the body, which is that bend right there at the LAD? Why is it most common right there? When you get that bend and you get this turbulent blood flow, boom, there it is.
Yeah, that's why it's, of course, one of the highest pressure. Yeah. Because it's a lot of people don't realize this, that the heart, we keep talking about the coronary arteries. It's the blood supply to the heart. A lot of times people get confused because they think it's literally the chambers themselves. So no, the reason the arteries of the heart, the coronary arteries, are, I think, as susceptible as they are, not just I think, but quite literally, is this state of the science is that it's not just that there's such a high and turbulent blood flow, it's that the entire geography of it is shifting and changing rapidly. There are very few arteries in the body that have that level of constant manipulation. And that's just stock and standard.
Yeah. And even the lungs, like they're expanding, but they're slower, whereas the heart is contracting and it's changing the morphology of the vessels constantly.
I heard you mention in another podcast that the heart rarely gets cancer, for example, and that you had a theory behind that.
Yeah, that largely has to do with the fact that the heart prefers glucose or fatty acids and ketones, which you look at Warburg's work, like ketones, you can't ferment those. And cancer is when, or at least things we observe in cancer, is that the mitochondria lose the ability to use oxygen. And so they go into fermentation. And if you can't, you have to use glucose to ferment. And so if your cells are reliant on ketones and fatty acids, ketones being non-fermentable, that's less likely to happen. The other reason, that's one reason, but the other one is heart cells don't divide. So literally, if you force a heart cell to burn more glucose than it wants to and go to fermentation, it'll die before it divides, which is what happens in that mechanism I talked about with heart attacks that can happen with no blockage. You're forcing the heart cells to burn more glucose, and rather than become rapidly dividing cells, they just die. So it's very, like Warburg said it himself, cells that die are very unlikely to become cancer.
But I now want to, as far as the lack of dividing, we got to still explain the neovascularization. Now, what I've heard recently, and I have not followed up on it, but I need to, is that macrophages can differentiate into endothelial cells, which is freaking exciting. If true, I haven't really followed up on that. But getting back to the fatty acids, here's a fun fact to know and tell. Part of why I'm very excited to research cardiomyocytes is that these heart cells, they don't just love fat. They love fatty acids coming off of VLDLs. They specifically love triglycerides coming off of ApoB lipoproteins. 70% of their fuel is coming from that. Not NEFAs, not carbohydrates, not even ketones. 70% specifically off of ApoB lipoproteins. And it makes a lot of sense because that's where there's just a huge yield. It's massive. So you have, I want to say a BHB, I looked it up at one time, has a potential yield of like 22 ATP. A glucose molecule, depending on who you talk to, anywhere from 32 to 36, something like that. A fatty acid, a long chain fatty acid, like a palmitic acid, for example, is like 106 ATP yield.
Yeah, I was going to say in the hundreds.
Yeah. But a rule of thumb that they usually go by is that a triglyceride is 460 when you include the glycerol backbone. Now, 10 to 20,000 of those are on board a VLDL that's leaving hepatocyte. 10 to 20,000. So if you do the math, you have potential yield of over 1 million ATP for one VLDL. And they're not even giving their full payload. They're giving a portion of their payload with each time that they're being attached to drop off those triglycerides through the lipase. It's so fascinating because, of course, it makes sense of the muscle cells that are in your body that are probably just endlessly hungry and happen to be positioned right next to the thoracic duct.
I know.
Like,
where the kind of friends are coming.
We want the dibs. We want them first.
Yeah, sure. Well, and because it goes into the atria first, and then it goes to the lungs, but it comes right back to the heart, and then goes right to the heart, right back to the heart itself. So yeah, there's very few steps between where you get that energy source and where it's delivered. Yeah, metabolically, and we're talking about metabolism. We're talking about harvesting electrons. That's the end stage electron transport chain that happens that makes ATP, which I think ATP is for a very different purpose than what people think it is. But that's a very important part of the process. We also get energy from other places. We also get those electrons from other places. So when we talk about a cell, the cell needs those electrons, that we use in metabolism to create the environment of a cell, to make ATP, to unfold proteins, to get structured water. I think that's the purpose of it. But then from a standpoint of our vascular system and the fluid water in the body.
I mean, it can be multiple things.
Yeah.
Right.
Yeah. I think we need energy from outside metabolism, which there's scientists,
energy from outside metabolism.
Electrons from outside metabolism. So that largely comes from...
In other words, not necessarily from everything you eat.
Right. Yes. Right. Yes. Good. I think that we get into trouble if we try and get all of our energy from food. We end up overeating calories.
Yeah, I think we have no choice on that. I could be wrong about this, but I think you actually die if you have no sunlight for a certain period of time.
Yeah, exactly. Well, and the thing is that, so you mentioned EPA.
I know there's been experiments where they've isolated, maybe I can't say that, but I think that there is something to, anyway, I don't know.
Well,
I'll have to look it up.
They got those, there's lots of people that have just gone into a cave for however many days. And they're lots of them, they're studying circadian rhythm disruption because you're just getting constant darkness, studying that. But I don't know.
If I remember correctly, the one that I saw that was one of the longest that I had found, they were in there for a long time and they ended up in a 40-hour day-night cycle. So rather than 24 hours, their circadian rhythm adapted to something that was more like a 40-hour cycle, something like that. It was fascinating. But I think that there really is maybe something detrimental to the point of being fatal if you can't, if you get literally zero.
Human photosynthesize.
Yeah, exactly. If you get literally zero infrared.
Yeah. Well, the thing is, so you mentioned EPA earlier, and I don't think this is true of EPA, but I know it's true of DHA. DHA, it's a fatty acid, omega-3 fatty acid. We get largely from seafood, animal foods, that kind of thing. It has what's called a pi electron cloud around it. And when light energy hits a pi electron cloud, it excites it and creates DC current. It's the photoelectric effect that Einstein found. And so when we have DHA in our skin and we get sunlight, you are literally creating electrons from sunlight. You're turning photonic energy into electrons through DHA, which is why animal foods, I think, are so critical, because that's where we get all of our DHA. And like ALA is not going to do that, and we very poorly convert ALA to DHA. But that's one thing. The other thing is that when sunlight hits melanin, it's concentrated in many places in the body, but there's many scientists that have found, I found somebody talking about it from 1904, knew that this was happening. And then more recently, another scientist named Herrera is his last name, from Mexico. But melanin has the ability to take in energy, not just solar energy or light energy, but various forms of energy, and use it to dissociate water. And when it dissociates water, it creates molecular hydrogen, oxygen, and electrons. You get free electrons from that. And then actually when it reassembles water, you get more electrons that are produced from it. So melanin is not just this thing that gives us the pigment of our skin. It's actually a very active role in giving us electrons from our environment. It's also interesting that when you dissociate water, you get molecular hydrogen, oxygen, and electrons, which are the exact things that mitochondria use to make ATP. And it's very interesting that happens. And then also, so that's from the sun directly, but then also we talked about grounding and how the sun is concentrating energy into the earth, and then we can soak up the electrons from that. So there's other places that we're supposed to be getting energy in the form of electrons from that we're largely divorced from. And so then we're trying to get all of our energy from food, and we end up eating too much food, trying to get those calories, trying to get enough electrons that we should be getting it elsewhere. So I think a lot of that plays into why you look at studies like people with more sunlight have less heart disease, like just associations like that. If we want to try and explain those associations, those could be it. We're talking about energy, really. And when you don't have enough energy in your system, you can't maintain order. We get disorder, and we call that disease.
Let's lighten it a little bit. How have you changed your diet since the MI?
Not at all. It's exactly the same as it was since I discovered low carb. So yeah, it's primarily animal-based foods. And, I may have some carbohydrates here and there, but it's just easier as a type 1 to maintain stable blood sugars without it. Especially if I've been so low carb that I get into this state of like physiologic insulin resistance, and then I have a few carbs and my body it doesn't know how to deal with them almost. Like the insulin signal is not there for like a day, so it doesn't encourage me to keep eating carbohydrates. But I'm not opposed to carbohydrates, whole food carbohydrates for most people. Just for me, it's just easier.
It is a funny conundrum because type 1 diabetics, I feel like a lot of type 2 diabetics have more options. Like if you want to make a case for a particular diet, being a type 2 diabetic, there's a case certainly for low carb. But I have type 2 diabetic friends and family who say, aren't there other options? And I'm saying, as long as it's low insulin resulting. Mm-hmm. Like you can have carbs as long as you can keep the carbs low enough that you don't find yourself in a state of being hyperinsulinemic in the morning, right? Or if you're past that point, hyperglycemic, right? In either case, both of those are low. Whatever diet you're on is probably the right diet. Can work. I feel like it's different for type 1 diabetics. I feel like the standard of care, honestly, should be try your best to get them started on low carb as early as possible. Because, and I feel like Dr. Bernstein really proved it, the law of small numbers, that trying to match the degree of carbs you have, the more carbs you have, the higher the glycemic effect, the more you got to cover it with insulin. And so the roller coaster is you've got to bring up this other one, and you can never quite line them up to where you get just the right amount of coverage from exogenous insulin to shuttle away the glucose.
Yeah, and there's just so much more too. Like the fact that if I didn't feel nervous, but when we started, if I was nervous at all, that would have raised my blood sugar, or if I go work out, that's going to raise my blood sugar. Yeah.
And it raises it from your glycogen release.
Yeah. I'm increasing cortisol.
So it's like you get glucose that wasn't coming from your diet, but that you still have to care about because you can't handle it as a type 1 diabetic in the same way someone like me would.
So there's so many factors and so many different things. Like if I'm just going through a stressful period of life, I'm a little bit insulin resistant, or I'm also injecting. So like the insulin that I'm giving myself is not going straight into the bloodstream. I'm expecting it to go in. Sometimes it doesn't go in as well. So it's just all these different factors that play into my ability to, which is why no matter how hard I try, it's never going to be as normal as someone who's not type 1 diabetic. Although I've met type 1 diabetics who seem to keep it that way, but I've met lots who can't. And it's just across the board. I know there's different forms. There's LADA and there's all these Modi forms of type 1 and all this stuff. I know people that can just control it with diet. Is that true type 1? I don't know. Why it just manifests
like it's not true type 1. I feel like it's insulin insufficiency, and there is some threshold they managed to get below.
Right.
Where the beta cells of the pancreas, which is what's releasing the insulin, they're so limited, but guess what? There's still just enough.
Yeah.
That they can manage to work
find
with
where
those
it is dietarily to create that. Yeah. And I know that like that group in Hungary, they, in a child, they put him on like a carnivore diet as soon as he was diagnosed, and they were able to reverse type 1 in that kid. And as far as I know, 5 years later, he's still fine. So if I'd known that, maybe I would have tried that when I was 9 years old, but I don't know if that would have worked or not. So,
but this gets back to the challenge of standard of care with regard to what diet they're going to tell you need to be on. So I had somebody I knew who this happened not too long ago when I was visiting them in the hospital, and they tried to stay ketogenic, but they had an event.
Mm-hmm.
And quite literally, the hospital had the kitchen. They have a heart healthy diet, literally called heart healthy. The kitchen pushed back on them ordering salmon, said it was too low in carbs. I kid you not. That was literally the statement from the kitchen, that meal was problematic because it was too low in carbs. I was dumbfounded that that's a thing, but it was. And I think that, and again, I'm trying to be fair. My guess is they're thinking about it in terms of, no problem, we have insulin here in the hospital. So if there's elevated carbohydrates because they're diabetic, no worries, we'll have this insulin that we can apply.
Yeah.
From their perspective, I think that they don't consider insulin to be that problematic.
Yeah.
I think that's just kind of more of the thought process.
Yeah. Well, they see it as necessary to control this person's condition, right? So it can be bad. It's this miracle thing which it was life-saving in the type 1s. But that reminds me of another thing that happened to me in the hospital, was that they wouldn't let me administer my own insulin. So
as a type 1 diabetic?
Yeah. And because I guess that's liability stuff. If something happens to me, I'm administering my own drugs, they're liable. I don't know. I'm guessing that's what it is. But it was incredibly frustrating because here I am freaking out that I need to heal and that this happened to me. And my blood sugars were in the 300s. And they were just basically like, they would come in at meal times. They would calculate my meal, what my blood sugar was, and give me this sliding scale like dose. And then if it didn't go down with that, I couldn't have insulin until another meal. And I was just like, that's not how I do things. If it didn't work, I give more. If it's not down to,
so they were just more comfortable with you hovering at much higher levels of glucose.
It was in 200-300s until I smuggled my own insulin into the hospital, and then I was able to do it. So, but there was even a nurse there that she was like, yeah, I don't understand why we don't let type 1s just do it themselves. Because and they took my A1C and it's low 6s, which I know type 1s, they get it much lower than that. But that's really good based on their standards. Like, they know I can do it. Why not let me do it?
Yeah, you may be right, though. It might be a liability in that they're worried if somebody on their watch administers too much insulin, they go into a diabetic coma.
Yeah, or they're giving me other medications that I don't know, like they just have to be able to monitor that. I get, and it is a liability thing.
It is crazy, though, because some of the more challenged cases in my friends and family will say things like they've never seen their glucose below 200 or something like that. And yeah, I have the reaction you have, except there's somebody close to me in my life who I'm like, can we talk about this?
Yeah.
But you got to imagine they're in the hospital. That's just a common thing on the screen for hospital staff. Mm-hmm. And wow, you have yours as low as 160? That's great for, another diabetic that I'm seeing. Of course, you would want to hope that there'd be more of an interest if the patient wanted to get their levels down and said, hey, this is where I'm used to having it. Can we try to get down to this? Would be better.
Yeah, I even know people that, so among type 1s, I've met a lot of different ones, and some of them can't feel a low blood sugar. Like it goes low and they're just talking to you and they don't know it's low and they just pass out. I've met type 1s like that where I've always been able to feel it instantly, but I have also met type 1s, type 1s and type 2s that it's so high for so long that if it gets down to like 100, they feel like they have a low blood sugar.
Yeah.
And that's not low. It shouldn't be giving you that signal. Yeah, so your body can adapt to those ways, sometimes not adapt in a good way, but it's very different, I've found, because as much as they want to make it a standard, and even if their standard of doing things is wrong, it's very different across the board. Different type 1s, different type 2s. And yeah, I mean, talking about this, I want to bring up too circadian rhythm and how much of an impact that has had on me regulating my blood sugars. And if you look at the literature, I mean, light signaling naturally would have come from the sun, as far as like the blue light that's bright enough to actually signal that it's daytime. That plays a huge role in our hormones. And it's literally signaling every single one of our hormones what to do, when to do, how much to do it. That's light signaling through the eye. If light signals through the eye hits the suprachiasmatic nucleus, that informs the pituitary, hypothalamus, and pineal glands, which are the regulators of all our hormones and signalers for all of our hormones, what to do. And so if your circadian rhythm is off, meaning your body is getting light signals at times of the day when it shouldn't be getting a strong light signal, like after sunrise or before sunrise and after sunset, then it's incredibly disruptive to your hormone signaling. And that's a huge issue in as far as like what's building up to poor metabolic health. And there's a ton of literature that shows that disrupted circadian rhythm is very, very heavily associated with higher metabolic health issues, specifically leptin, insulin, and then diabetes. So I think that's really setting the stage, just based on how much literature there is on it. And then the processed food diet is just fuel to the flames. So lots of people can go off the carbs and go on low carb and they take all the flames away, but the embers may still be there, but they do. And then they see these huge results. Their blood sugar regulates, their insulin comes down, everything. I would encourage them to set the circadian rhythm. And from a type 1 perspective, it's been a huge deal for me. So I do circadian light, but I also do circadian eating because that makes it easier too, as far as like when my body is designed to digest, when it's going to digest best, which is when there's daylight hours, when it's not able to digest as well, which is during the night. So if I do that, it makes my insulin signaling that much better if I coordinate the hormones there through light exposure. So yeah, and if you just go into PubMed, you type in disrupted circadian rhythm and any disease you want, there's links to it, So
it's actually a weakness of mine. I don't get as much sleep as I want.
Hey.
And what I find is, like, I average, I want to say like 5.5 hours a night. I find that most of those nights I sink in deep. So I do have like an adequate amount of REM and deep sleep.
Mm-hmm.
However, it's fragile. Mm-hmm. So whereas before, when I mean, granted, I only have the numbers I basically get from my Aurora Ring, but I tend to find it matches with what my mood and stamina levels are, in that if there's interruptions, if I stay up later than I intended to, something along those lines, it's not easy to make up the difference.
Yeah.
Like there's not a lot I can do about that. But I keep suspecting the study is a big part of it. The study takes a bit out of me, working on that. Yeah. But I figure at some point I'll be kind of graduated out of the core study. We have a second study that's coming up, but I'm going to have a study coordinator by that point that's going to be helping us with Citizen Science Foundation. But getting back to the whole loop of stress being its own cardiovascular risk factor, or just overall life risk factor. It's funny how often the best medicine is out there, right? It's like, go outside, makes a difference.
Yeah, I think that again, there's that inherent wisdom there, right? When we look at in the modern day environment we've created for ourselves, is giving us constant stress signals, constant unsafe signals, right? Whereas if we look at, yes, the natural world, getting enough sunlight, being in contact with the earth, being out in the natural world, there's less EMF, there's less of these non-native electromagnetic fields, which I'm talking about wireless signals and like electricity running through the walls, creating an electromagnetic field. And people they say, oh, that stuff's fine, all this kind of stuff. It's like, well, until proven innocent, I'm assuming it's guilty. Because, if we look at what humans were exposed to, the only, light signals we were exposed to was that of the sun, UV through infrared, right? And wireless is a light signal. It's on the electromagnetic spectrum of light, which means light carries information, because I can pick up my phone, I can call you and send a light signal to your phone, and it carries information. So what light information are we getting from our modern day environments? Talking about artificial light versus natural light, it's totally different information. And so, but you look at all that stuff, and you realize that we're constantly giving our bodies a stress signal, which means we're ramping up cortisol. We're telling it all the time to be alert and ready for something. And then you go back into nature and you get more calming signals, which I think it's funny that we call like recreation areas recreate. We're trying to recreate the natural environment of humans. That's what we're trying to do and there's a reason that we gravitate towards those things. We go to national parks, and there are a lot of people, not everybody, but we seek out those areas. Why? Because we feel calmer. What are we doing on the beach? First thing we do, take our shoes off. We're in the sun, we hear the surf, the sounds of nature. It's calming. We like it. And there's a reason that is. And then we come back to these environments where, in big cities, artificial light, EMF, past trauma, all this stuff that happens that just ramps up cortisol and keeps it so elevated. So that brings me right back to hormones and how important it is to set your hormones, to signal your hormones. If you're giving your body all these stress signals that are ramping up cortisol, that's going to lead to leptin resistance, which is going to lead to insulin resistance, which is going to lead to insulin, or issues with blood sugar eventually, because you pick it up way before it becomes that. And it's all stress. It's all this response to stress. So it's really, really important, because cortisol and melatonin switch. They're supposed to switch. So cortisol is the hormone. It's not like the stress hormone. It's the hormone of daytime, really, of alertness, during the day. And the signal the major signal that we get for that is blue light, because when the sun comes over the horizon, we get blue light exposure, and that tells your body that it's daytime. And then it rises, blue light rises throughout the day, and it peaks at solar noon, which is not always noon. And that tells your body that it's midday, and then blue light starts to fade away. And as it fades away, we produce less cortisol. We're supposed to be less alert, and then darkness comes, and without blue light, we're supposed to get more melatonin. And when melatonin comes, then that's signaling your body to go to sleep and get ready for sleep, become sleepy and tired, right? And melatonin, though, is not just this hormone of sleep. People use melatonin to try and sleep, but it's not that. It's like one of the most potent antioxidants in the entire body. Go research like melatonin and artery health. It's amazing for artery health. It's actually been shown to stabilize rupture-prone plaques. Because it's creating a less inflammatory environment. It's an antioxidant. And we get melatonin from this shift in the day-night cycle. So 95% of our melatonin, though, comes from near-infrared light exposure from the sun. So we're getting less sunlight. And then B, we're also disrupting circadian rhythm. So if you have blue light exposure after sunset, you're shutting down your pineal melatonin production, which A, is going to disrupt your sleep. But if you don't have enough of that 5% of melatonin that's made from the pineal gland, you're not going to sleep. Melatonin, or having adequate melatonin, also signals for autophagy and mitophagy when you sleep. It signals for deep healing sleep. It signals for detoxification in the liver. And it signals for all kinds of healing that's supposed to happen, including the lining of the artery. And if that doesn't happen, so that's why I lumped that into earlier when I said we have less infrared, we're not protecting, we add the insults, and then we're also interfering with the body's ability to heal. We have poor insulin signaling from this epidemic of type 2 diabetes. We also have disrupted sleep from disrupted circadian rhythm, which if your body can't heal at night, the plaque just sticks around. The inflammation, the lining of the artery just sticks around, and it doesn't, and then the body just has a continual response, and it builds up over time. It's like, I tell people, if you don't get enough melatonin to sleep, it's like you never took the trash out in your house. Eventually, you can't live there anymore. So that process needs to happen every single night, and it's huge for healing. So yeah, And that's just one of the ways that you look at stress. Disrupted circadian rhythm is a huge stress signal. It's like your body doesn't know what time it is ever. And that's very stressful to it. And then there's many other things that can cause this.
Did you ever do the blue light glasses or anything like that?
Oh, yeah. So typically I'd be wearing them now because there's some blue light here. And that's, I want blue light signaling during the day, right? But imbalanced light from the sun, like we would never get that high amount of blue light like an LED provides us or a screen or something like that without a bunch of red and infrared too. So the red and infrared, as soon as the sun comes up, the red and infrared stays here, and the blue light is what changes throughout the day, right? An LED bulb is like a bunch of blue light here, and the rest of the colors are almost non-existent. They're there, but they're almost non-existent. And so that can be harmful to your eyes, getting that imbalanced color. So you probably see me at one of the conferences, I was wearing yellow glasses, and that's blocking the blue from that stuff. But then from a circadian perspective, you ought to be cognizant of the light exposure before sunrise and after sunset, when you're telling your body when the sun is up, right? So if you have LED bulbs on or fluorescent bulbs on, fluorescent are really high in green light, but the blue is mainly from LEDs and screens and things like that. If you have that on past sunset, you're telling your body it's noon. And then it doesn't prepare for sleep. And then even if you fall asleep, you're like, oh, I sleep well. You may not be getting full healing and repair like you should be because you don't have the 5% of melatonin that's supposed to be created when you block that blue light. So after sunset, I'll wear the orange glasses.
I have some habits of my own that I definitely want to change coming into it. One of the issues is just that I work so late on screens. But I actually thought about that particular thing, seeing if I could have a dynamic backdrop, at least, right? A different desktop change in and of itself. I don't know how much that would make a difference. But.
Well, there's programs you can get that'll turn down the blue light on your computer, like on your screen or on your phone. Like I think Apple phones is programmed into it. You just gotta look
for the setting.
Yeah, look for the setting. Whereas Android, you gotta download an app to do it. But yeah, like I wear the glasses. I use incandescent bulbs after sunset. I have like 6 or 8 lamps in my house that I just use with those in them, and they're not as bright. Like people may find that annoying, but they're not. Or if you're working on your computer and it's very color based, your work is, like if you're some kind of graphic designer or something, then it's not very nice because you don't have the colors there because it's dimmed, and that's annoying too. Or if you're wearing glasses, it looks different too. So I understand all that stuff, but the most important thing is just recognize that it's affecting our physiology in a big way. Literally tens of thousands of studies now showing that circadian disruption, especially like hormonal cancers, breast cancer, prostate cancer, those types of things, it's a big deal. Which makes sense, again, because it's signaling for all your hormone production. So, yeah.
So, I have to embarrass you for a moment. Your citizen science talk from our from our collaborative science conference, which is, of course, a fundraiser dressed up as a conference. Well, sorry, I should set this up a little bit more. So we have featured speakers at our conference, which are a lot of the big names that are already out there and themselves often educators or doctors or researchers. And then we also have this like category of citizen science speakers, which include a lot of names themselves, but it's like we can only fit so many in. And so of the citizen science speakers, you're stuck with 14 minutes, hard 14, and you got to give your best talk, and it might be like a TED Talk level. You did one for us. I want to say it was the first one, right? Mm-hmm. The first COSI. Mm-hmm. And it is hands down the most viral one. I want to say, last I looked, it was around 300,000 views, something like that. So, of course, we release all of these as videos in and of themselves. Yours was absolutely high-flying. And it's the reason why for this third and last COSI that we're going to do, we wanted to invite you back to be a featured speaker. So I'm excited because I think you'll be able to kind of expand a bit more on these hypotheses that you have. Mm-hmm. And I'm also very excited that people were so interested in the structured water hypothesis itself. That's very fascinating.
Yeah, I'm glad they were too. Obviously, and was not expecting that, but I kind of tracked it for a while, and I was like, oh, people are still watching it. People are still watching it.
Yes.
And I was like, oh. And then I got clients from it too. And I was like, oh, they're like, I always ask them how they heard about me. And yeah, I saw some video of you. It's 17 minutes long. And I was like, oh, I know which one that is, you know? So yeah, I'm very happy that they're excited about that too, or that they seem to be interested at least. Because I think that it's important to talk about this stuff. I mean, again, the biggest issue I had with anything in the hospital was the shutdown of conversation about any of the questions that I had. And so if people are interested, that just makes me happy.
It was kind of an eye-opening experience for me, this recent period where I needed to visit somebody in the hospital. And I don't go there very often. I don't go to a hospital to visit people who are there for a lengthy period of time. But I will say that that one was a bit tough on me. Because again, I want to be sympathetic to doctors. First of all, they're pressed for time. The good and bad doctors, right? They're all pressed for time. So to some degree, they're just trying to make do with what they've got. They have to make key decisions that can't always have the world of information at their feet. But all of that said, I do know that there is a kind of two general categories, or at least a spectrum. And on one end, there are doctors who are like, oh, you seem to be taking this disease state or this event very seriously, and you're trying to be educated on it. And I'm not going to assume your level of education for it is shallow. I'm not going to assume you're just a busybody and you're going to throw, the moon was in retrograde or whatever. I don't know. You seem to be bringing forward to me things that are in my field. You seem to be bringing forward to me studies. You know what? I'll take a look at it. I know doctors who are like that.
Yeah.
There's the other end of the spectrum. It's like, why are you showing me any resistance? I'm the expert here. I can appreciate that you are taking a little time to check in on Dr. Google, but I'm the doctor.
Mm-hmm.
That's like the other end of the spectrum. I've met a few of those as well in this care experience. And it was tough because this is the part I think you only get to know once you're either a patient or you're a loved one of a patient, which is this kind of vulnerability, this sort of like fear that you're going to upset the people who are in charge of very key decisions around what happens to you. And that was kind of tough. I got to be honest. That was an eye-opening experience for me.
Yeah, sure. And I obviously know how that feels. The first attending physician that I was under the care of in the hospital was one of the ones that was just like, why are you not listening to me? And just kind of shutting everything down. And most of them were. And I found a few of the interns were more open, and they were learning, and there was a resident that was finally the one that, upon my request, like 3 different times, she was the one that came in and like explained things to me, because they were saying this kind of stuff. And I was like, well, can you show me that? I'm actually really curious about why you're saying that. What does my echo show? Like, explain the images to me. Like, what are you seeing? And a few different doctors did that. So yeah, it's across the board. And I also know that it was a teaching hospital. And so they were in there, like the attendings were in there with students. And if I'm asking questions they don't know the answer to, it's not very likely that they're going to say, oh, I was wrong or anything like that to look bad in front of their students or whatever. So I recognized that. And like, I wasn't being combative. I was just more disappointed.
Which is also important. It's not like it's not as if we can say we don't understand how there could be people on this other end of the spectrum who are the doctors if you're the 25th out of 25 who all were giving resistance for other reasons before that point. They're human like we are. There's a certain degree of generalizability to the patient that does seem to be non-compliant. That's to some degree understandable. That said, you're still a patient.
Mm-hmm.
Your thoughts do matter. To some extent, you should be able to interact, ask questions, understand more. I think that should be a given.
Yeah, and I think that I've kind of identified, because I went through it myself, so I know what it feels like. But I've also worked with a lot of people now, and working with people, I start to realize what I'm really helping them with. Because right now, where people are at, they either get their lipids back and they're super high for whatever reason, right? Or they get a CAC score and it's really high. They don't know why. They're trying to take care of themselves, or they have a heart attack, right? And out of the blue. And that scares them. Those things scare them. Or in the case of lipids or whatever, the fear is put into them, by the medical establishment. Or if a doctor believes that that's, the cause of heart disease and they're going to die. But the problem with the philosophy, it's not necessarily the people in medicine. It's the philosophy of it that's creating fear in people, which is very disempowering. So then someone has been listening to people like us, right? And they know that maybe LDL is not the whole thing, or they know that statins aren't right for them. They don't want to do that. They've already decided that. And then this happens to them. And then they're in there, and the fear of God's put into them that they're going to die unless they do something about it, unless they take this drug. But they know they want to, they know where to go from there. And so what I've found, based on my experience and what I attract as far as people I work with go, is that people are in that situation. I had to find a way out myself. Whether or not my theories are correct, which some of them may not be, but if we don't have the ability to talk about it, that's the problem, right? So if they shut down the conversation, which is what happened in the hospital, which I know is happening to other people in the hospital. So I've kind of this is the part that gets sentimental. It's like, this heart attack was the worst thing that ever happened to me, but it's also the best thing that's ever happened to me, because it led me in this direction. And now I'm helping people recover, or even just mentally recover from this, and find a philosophy or find a way of doing things that empowers them again, gives them control, which they're not getting from medicine. They're being told, take this or you're going to die. That's the only way. And it's not put like that. It's probably said nicer than that, but that is what's happening. And that creates fear. It's an external locus of control. And so what I had to do for myself is find a way to bring that power back into myself and do this thing. And then it worked. I was like, oh, it worked for me. I can't say it'll work for anybody else, but it worked for me. And now I get to go help other people. And it's been the most rewarding thing. It's amazing to do that. So it comes full circle. And there was a reason that it happened, I guess.
Well, are there any other hypotheses we haven't covered yet?
As far as atherosclerosis?
Yeah. I think we ran a pretty strong gambit.
Yeah. The only other thing I could say is that from a heart attack perspective, obviously we talked about it could be an acute clot situation big enough that could have happened to me. And I think, because earlier I said, and I don't know if we got into this enough, I said that you get a high CAC score. Technically, that puts you at higher risk of a heart attack. But the most important question is why? Is it because a plaque rupture happens? I don't know there's really that much sound evidence for that. People would argue with me about that. There's one paper called The Myth of the Vulnerable Plaque that puts a pretty good dent in that theory. Plaque ruptures happen, but they just cause more plaque. You can just kind of build the plaque up over time. But they say that they rarely cause heart attacks. So I think that heart attacks, even if it is a blockage variety, it's more of an acute clot situation. And that happens when we get poor stagnant blood flow. And if we have plaque in an artery, you get a CAC score and it's there, the reason that it increases your risk for a heart attack is because it disrupts blood flow. We've got blood trying to go over these bumps now, creating turbulence and eddies and things, turbulent blood flow. And especially if we're dehydrated, or if we lack structured water creating blood flow, or we lack structured water around the blood cells, so the red blood cells are clumping together, this situation just perpetuates clotting. And if a clot forms and you have a blockage there and there's no collaterals, let's say 50%, they say that 50% blockage are the most dangerous ones, because they say for some reason the plaques are unstable, right? Well, what if it's because there's no collaterals yet, and it's disrupting blood flow and a clot forms there and there's no collaterals to compensate for that? So just different things like that, I think are important to note, because then it becomes, for me, even if I gave this small talk to a group of people they were asking me what would I do if that clearly scan came back riddled with plaque? I would increase blood flow. I would make sure that despite the plaque, the blood is moving through there and it's the least likely to clot as possible. I would build the structural water, get the infrared light, do the grounding, everything like that, keep blood moving so that it doesn't clot. And I think that's an important message for people.
I think my cardio friends would be, wait, if there's a lot of plaque, you've proven lipid hypothesis. It's only like increasing further because of the higher LDL.
Yeah, they would say that. But I would just go right back and say everything that we just said in this podcast suggests that it could have happened a completely different way. The lack of blood flow, insult to the lining of the artery from various things, fluctuating blood sugars, whatever it may be. Like there's things that have caused insult that cause the plaque. So again, that's the issue with observing two things happening at the same time and trying to draw conclusions from them. You can't do that, or you can, but there's a very high likelihood that it's going to be inaccurate, or we can't bet the farm on that.
Well, one thing I'm certainly looking forward to, which helps bring us to a nice ending, is our study doesn't just have people with clean arteries. We have people who have existing plaque, which granted, some number of them will have potentially acted on, maybe even changed the diet or so forth. Some won't have. When we have 5-year scan data, that'll be gold. That'll be some of the most powerful data you can imagine, because exactly what you were just now talking about, some number of them who have the plaque, how much will their LDL have that association?
Mm-hmm.
I'm very interested.
Yeah,
knowing what that is.
The famous thing is you say in the study that says plaque begets plaque, right? So is that plaque begetting plaque because of LDL, or is it irrelevant? Or it's because it's disrupting blood flow and that's creating clotting, so more plaques forming? I don't know. And I remember asking you at the last conference that came up, and I was like, do you have any like lifestyle data from these people? Like, are the ones who saw regressions getting more sunlight? Or that would be interesting.
Yeah,
interesting to see.
We may do one of these like follow-ups with the people who have regression. The catch is that, and I've stated this plainly, my worry is that the sample size is so small that there may be too much of an enticement to look for a signal.
Yeah.
Where it could be something much more coincidental.
Yeah.
And that would be my concern.
Yeah.
So Stephen, how do people find you?
My website is resourceyourhealth.com. So people are interested in working with me, they can go there, just, click on work with me as a client. My Instagram and Facebook is just Dr. Stephen Hussey, Dr. Stephen Hussey. People can reach out there, ask questions. I'm always trying to post things that I find and interesting and newest theories and things like that on there. So yeah, that's pretty much the two spots.
Well, it's been a pleasure. Thanks for coming on.
Yeah, thanks for having me.